A very good morning and a warm welcome to day two of the fifth edition of Endocrine Enrichment Program, EEP 2022. After a little over 4 hours of brainstorming yesterday, we are back this morning with another 4.5 hours of knowledge sharing in the form of three case discussions, in the form of a contest, the endocrine wise out, and of course, there's a lecture as well. To kick off today's proceedings, we have case discussion 4. The case will be presented by Dr. Mounam Chattopadhyay, who is a postdoctoral trainee at the Department of Endocrinology at NRS Medical College, Kolkata. And to take us through the case, to guide us through the case, we have two very reputed examiners who need no introduction in any part of our country. We have Dr. Nihal Thomas from Christian Medical College, Vellore, and we have Dr. Shotinath Mukhopadhyay from IPG MER and SSKM Hospital, Kolkata. Over to Dr. Mounam and the examiners to take us through case discussion 4. And while Mounam starts sharing his slides, in the chat box, we'll soon have the name of the group members, the participants who can be asked questions in sequence. We'll have that list very soon in the chat box.
Need not be in sequence according to the choice of the examiner.
Yes, sir. Of course. It's the examiner's discretion.
Hi, Dr. Nihal. Good morning. Shotinath here. Can you hear me?
Good morning, Satyanath. Good morning to everyone else as well.
Good morning. So, Dr. Mounam, you ready?
Yes, sir. Can I start?
Please.
Good morning, respected teachers and my dear colleagues. I am Dr. Mounam Chattopadhyay, postdoctoral trainee, Department of Endocrinology, NRS Medical College in Kolkata. Today, I will be presenting EEP clinical case number 4.
Mounam, sorry, before you start, it's not essential to reveal the name of the patient.
Okay, sir. Okay.
So you can just use the initials.
Okay. My case is a 60-year-old man who develops a swelling blackish discoloration followed by an ulcer in the great toe of the left foot since last 3 months. It was associated with occasional foul-smelling discharge from the ulcer. No, there was no history of fever. There was no history of any recent change in footwear. There was no history of preceding trauma.
Sorry, before you go to the next slide, Dr. Shotinath again. Yeah. So could you just tell us if the patient had all the three problems, swelling, blackish discoloration, and an ulceration, all for 3 months, or there was a sequence?
Sir, initially there was the swelling and black discoloration, which subsequently the swelling give way to the ulceration and discharge, and it appeared in sequence. First the swelling, then the ulcer.
So the ulcer was for how many months?
So ulcer was, sir, actually he did not specify the exact duration. He told the sequence of event occurred in the 3-month duration.
And where was the ulcer on the great toe? It's better if you mention that right at the beginning.
Yes, at the tip of the left great toe.
Okay, please go ahead.
Okay, sir.
Can I ask a question? I think some of the students must be online. Pooja Tiwari, are you there? If not, I can see.
Hello, yes, sir. Good morning, sir.
Pooja, yeah. Please tell us what are the causes for a sudden blackening of a toe in a person who has underlying, a person who has diabetes. You have a certain blackening of the toe. What are the potential causes?
So gangrene, setting of gangrene, sir.
Sure. Anything else? What are the other causes? Is it always gangrene? Very often a patient has a major concern that my toe has become black, but does it have to be gangrene? What are the other possibilities?
Infection, sir. Anaerobic infection.
Which anaerobic infection are you suggesting? Particularly the
Clostridium.
nail or the nail bed, if it becomes black, what should you think of?
Fungal infection, sir.
Yeah. Okay. Which particular organism causes this kind of blackening of the nail bed, particularly? Which fungal infection? You looked that up. Any other cause for blackening of the toe or the nail bed or the subcutaneous area?
Aspergillus niger.
Yeah, sure. But which? Okay, so that's fungal. But the commonest fungal infection is actually a rubrum. Which is the other cause for blackening of the subcutaneous tissue, which may not necessarily be in gangrene common? Post-traumatic hematoma of the toe. Very often it happens in patients who have diabetes and it need not be in gangrene.
Okay.
Right. And rarer, of course, you should think about conditions like melanoma, etc., which could be there. Yeah.
Yes, sir. Yes, sir.
Okay, please continue. Thank you.
Thank you, sir. He is a known case of type 2 diabetes, diagnosed 10 years back, and is on oral anti-diabetic agents. For the last 6 months, he is complaining of tingling paresthesia and numbness in his both legs below knee and burning sensation in bilateral feet, which was more pronounced at night. And he also complains of slippage of his footwears for the same duration. There is no history of alternating hard and loose motions, dryness of mouth, abnormal sweating or postural dizziness. There is no history of erectile dysfunction, no history of floaters, no history of progressive diminution of vision, no history of frothy urine or reduced urine output. There is no history of intermittent claudication, no history of exertional dyspnea, palpitation, chest pain, or syncopal attacks. There was no history suggestive of transient ischemic attack or cerebrovascular accident. Past history was nothing significant, and he had no history of past similar foot ulcers. Family history of diabetes was in his siblings. In personal history, his sleep was disturbed due to the neuropathic burning pain. Bowel and bladder habits and appetite were normal. He was a tobacco chewer.
Dr. Sonam, please hold it there.
Okay, okay, sir. Okay, sir.
So who is next on the list? Dr. Aruna, are you there? You're with us?
Yes, sir.
So if a person has his sleep disturbed due to neuropathic symptoms, in addition to what Monam has already mentioned, what other symptoms do you ask for?
Disturbed sleep, because of this aggravation of this neuropathic symptoms, they are mostly during the night time, sir, and also frequent urination that can also lead to this sleep disturbance.
Anything related to this burning sensation? Any other history specifically asked? Let us move down the list then. Dr. Venkata, are you with us?
Yeah, I'm here, sir.
So any suggestion? Burning sensation leading to disturbed sleep. So you ask for anything, any specific history? Okay, who is next? Anirudh. Dr. Anirudh, any suggestion?
Yes. Sir, good morning. Am I audible, sir?
Yes. So you have any suggestion?
Yes, sir. Sir, in small fiber neuropathy, usually you can have allodynia also.
Great. Excellent.
And Also, they can have electric shock-like sensation.
Yeah. Those are the things you need to ask.
Yes, sir.
And also the patients may have some problem in straightening the legs. There is some cramp-like sensation also. So good. Dr. Nihal, you have anything on this?
Yeah, so I think Maunam is next on the list.
Yeah.
Maunam, you have given
Yes,
this
sir.
history of no erectile dysfunction. Just go back to the previous slide. No abnormal sweating. So basically, are you saying that this patient does not have any autonomic dysfunction?
Sir,
Categorically ruling out autonomic dysfunction?
symptomatically, sir, he did not give any history that is suggestive of autonomic dysfunction.
Does that mean that autonomic dysfunction is absent?
So we have to test the patient, clinically examine the patient to confirm whether he is having autonomic neuropathy.
So what are the earliest signs of autonomic neuropathy? Signs.
Sir, dryness of mouth, abnormal perspiration, postural dizziness, that is dizziness after getting up from supine posture.
That's a fairly advanced sign. Once you have postural dizziness, it's a relatively advanced sign. So, which are the earliest signs of autonomic dysfunction? Anyone else? Pooja?
So erectile dysfunction.
Sure. Then what else? Very common occurrence besides erectile dysfunction. Dry skin.
Right.
So dry skin, even more than differential sweating, dry skin in the lower limbs is a feature of autonomic dysfunction due to dysfunctional hydrosis.
Okay.
Okay, you can carry on.
So summarizing the history.
I have another question. Aruna, are you there, Aruna?
Sir.
Yeah. He mentioned about sleep disturbances, right?
Sir.
And someone else was talking about nocturia. In this person, 60-year-old gentleman, if he had nocturia, what would be the potential causes?
Sir, that can be because of any benign prostatic hypertrophy with the age of
very good.
Yes.
What
and
else?
because of this uncontrolled diabetes.
Sure. What else? What else? Couple of other common causes. Can sleep apnea cause nocturia?
Yes, sir.
What's the mechanism?
Sir, I'm not sure of the mechanism.
Venkat, do you know the mechanism of sleep apnea causing nocturia?
Not sure, sir.
Anirudh?
Sorry, sir, I'm not aware.
Yeah, because of increased RV pressures, there's an increased production of ANP, atyl natriuretic peptide, and that can cause nocturia. Okay, carry on.
Okay. So summarizing the history, we have a 60-year-old businessman from Kolkata who is a known case of type 2 diabetes mellitus for last 10 years on oral anti-diabetic drugs. Presents with a non-traumatic ulcer in his left recto since last 3 months with foul swelling discharge. He also complains of tingling numbness in both his legs below knee and burning sensation along with slippage of footwear from both feet for last 6 months. He gives no history suggestive of autonomic neuropathy, nephropathy, retinopathy, or any other macrovascular complications, including claudication pain or waist pain.
Dr. Monam.
Yes, sir.
As Dr. Nihal was suggesting, did you specifically ask for dry skin? I don't think you did.
Yes, sir, I missed it, sir.
Yeah, okay. Go ahead, please.
Now,
go on to the examination findings.
okay.
One of the other things you mentioned in diet, just go back to the dietary history. That's, that's a rather superficial diet description. Do you have a recall on him?
Sir, I did a 24-hour dietary recall, sir.
You did. So would you like to mention that? That's pretty important, right?
Okay.
Would you like to break it down? You have it, Mona?
So actually, I don't have it in my slides, sir.
Okay. Anyway,
Mona,
just for the trainees, I think dietary recall is very basic. Has
Okay,
to
sir.
be documented.
Okay, sir. I will include this.
So can you, maybe the others would like to answer this question. Pooja, Dr. Maunam has mentioned that he's taking an average non-vegetarian Bengali diet. So what is your understanding of that? So increasingly in India, we are kind of, people are living all over the place. We need to understand this diets in different states. So what is your understanding of that, Pooja?
Sir, it will be excess of carb with rice based thrice a day.
So you said non-vegetarian Bengali diet. What would that contain? Anything else which might be dominant along with the rice?
Fish.
Fish.
Yeah, you should highlight that, right? Dr. Satyanath will correct me. If you're taking a non-vegetarian Bengali diet, you probably have fish at least once every day.
No second thoughts about it. Bengalis are fish eaters, and maybe that protects them from the bad effects of high carb. We can discuss that afterwards.
Is there any difference between a non-vegetarian Indian Bengali diet and a non-vegetarian Bangladeshi diet? Any difference?
Sir, I am not aware of that.
Okay. Maybe once again, Satyanath can allude to that. There's more meat eating in the Bangladeshi diet compared to the Bengali diet. Am I right in saying that?
Actually, in Bangladesh, they have an equal share of fish and meat. They also take a lot of fish in Bangladesh. But in our part, West Bengal, it's largely fish with meat taken occasionally. But Dr. Nihal, I would also like the participants to note that this diabetic food is kind of a long case in your exam, and diet will be invariably asked. So Monam, if you had taken a 24 hours recall even, so we would like to know whether you were able to break it up, as Dr. Nihal said. And it always makes sense to have at least 7 days, a week's diet recall to get a fair idea of what the patient actually eats. Dr. Nihal, if you have nothing more on this, can we move on to the next slide? Ask him to move on.
Absolutely.
Okay.
Thank you, sir. Coming to the examination, his pulse rate was 86 beats per minute, regular. Blood pressure was 150/94 millimeter of mercury, measured in the right arm supine posture. There was no postural drop in his blood pressure. Height was 167 centimeters.
No, before that, Monam, it makes sense to mention that all the pulses are palpable, or whether there are...
Yes, sir. Pulses were palpable in both his arms, but it was feeble in his left feet distally. Left foot distally.
Left foot distally means?
Left foot distally. So distal pulses, the arteria dorsalis pedis and posterior tibial arteries.
Okay.
That I will mention in the local examination.
Okay, please go ahead.
Yes, sir. Height was 167 centimeter, body weight 65 kg, PMI is 23.2 kilogram per square meters, waist hip ratio is 0.9.
How do you define this waist hip ratio for an Indian? a male subject, is it okay, or any idea? Yes, Pooja, Dr. Pooja. Dr. Pooja, are you with us?
Hello, yes, sir. Sir, 0.85 is the cutoff, sir.
Right. Okay. Then, Monam, go ahead.
Yes. SMR was A plus P5 G5. Acanthosis was present, or grade 2 acanthosis was seen. There was no pallor, no icterus, no cyanosis, no pedal edema could be found, no clubbing and no lymphadenopathy. There was no goiter, skin tags or vitiligo. There was no localized hyperpigmentation, xanthelasma. There was mature cataract in his right eye and pseudophakia in left eye with history of cataract extraction and IOL implantation. Retina on the left side could be examined and it's normal. Other systemic examinations were within normal limits.
Aruna, can I ask you a question? If you have a patient who has diabetes and you have looked at the retina, there is no diabetic retinopathy. What is the other important finding that you need to look at in the retina if there is, even if there's no diabetic retinopathy? So this alludes to the third commonest problem which occurs in the eye in patients who have diabetes after cataracts and retinopathy. Therefore, you would look for this finding in the retina. Yes, Aruna? If not, Aruna, next, Venkat. What else will you look at in the retina? Anuruddh?
Sir, involvement of
yes,
sir,
yes. Tell me, Anuruddh.
Sir,
yeah.
Involvement CRVO is also common in diabetic patients, actually. CRVO, and
that's common. I mean, it's that would come way down on the list. So something else, which can be, if you know how to look for it, it can be picked up. So you look for cupping, right? Glaucoma, open-angle glaucoma is more common in patients with diabetes. So you may have to look for cupping of the disc. Yeah. Carry on.
Okay. In the local examination, in the examination of both his feet, in the left side and both in the left and right side, we have found cracks and fissures.
Monam, let me stop you here. So, okay. How do you explain the cracks and fissures?
So cracks and fissures are formed due to dryness of the skin and
dryness of the skin is due to
autonomic dysfunctions.
Which fibers are involved?
Just small fibers, small fiber neuropathies.
No, they have a particular name. Which group of fibers are responsible for maintaining the skin moisture? This is the question Dr. Nihal asked you at the beginning. And we have gone through the slide set, so we have seen the feet. Definitely the skin is dry and there are cracks and fissures. So a sure sign of autonomic neuropathy is there, right? Yes, anyway, which fibers? So again, down the list, Venkat.
C fibers, sir.
Any special name for them? Anirudh?
Sir, unmyelinated. They are not myelinated.
No, C fibers are unmyelinated. That's fine.
Yes.
Then who else? Aruna, back to you.
Small fiber. Name specifically.
So pseudomotor fibers.
Okay.
Are you aware? Familiar?
Yes, sir.
They are the fibers responsible. Okay. So, okay, fine. Dr. Nihal, you have anything on this? Dr. Nihal, are you there?
Please continue.
Okay,
Okay, sir.
please continue.
Okay, sir.
Yeah.
Callosities were found on his both feet. Callus was present on the lateral aspect of the little toe on the left feet, along with dry skin, and there was loss of hairs. Callosity was present in the dorsal aspect of the right feet. There was also dry skin and the hair loss.
Sorry, Monam, when you describe one foot, so you say foot, and when both, you say feet. And again, coming back to the cause of loss of hairs. So you have any idea?
Sir, hair loss can be seen with peripheral vascular disease.
Yes, good.
Vasculopathy.
Right. Okay. Go ahead.
There was.
You mentioned about callosities on the sole of the foot. Which are the common sites for callosities in such a patient?
Sir, mainly the areas of weight bearing, like undersurface of the great toe, the head of the metatarsals, the medial malleolus. These are the common sites for developing callosities.
Medial malleolus? Why? Did you mean medial malleolus, or you meant something else? Why should the medial malleolus be prone for callosity?
So due to friction with the footwear, the back end of the footwear can develop.
I mean, I guess anything which has a strap which overlaps can cause it, but that's a little high up. Medial malleolus is a bit too high for callosity development.
Yeah, Monam.
If at all, lateral malleolus.
Yeah.
But why? Lateral malleolus can develop thickening of the skin. What's the reason? Can we go on next? Pooja, can you answer that question?
I don't know, sir.
Aruna?
Pressure,
Lateral malleolus.
repeated pressure while in the supine position. Or,
While sitting cross-legged, that's how it actually happens. Okay.
So, Dr. Nihal, sorry, but I mean, it's a bit surprising that none of the participants has seen this. If you see diabetic patients with foot problems, quite often you will come across with this. And so going back to Monam, now do you agree that you were actually referring to the lateral malleolus and not medial malleolus? Or you are not sure?
And I was not sure, sir.
So you haven't seen callosities on lateral malleolus?
Sir, yes, sir, I have seen, sir.
Due to sitting cross-legged?
Yeah. That area becomes.
And then may I ask you, on which side is this callosity more common, on the left lateral or the right lateral?
So right.
You are right, but then can you tell us why?
So because in cross-legged posture, right lateral malleolus comes in contact with the.
Good. It's always the right lateral malleolus which is touching the floor. Yeah. Good. Go ahead.
There was deformity with loss of arches and clawing of the toes that were present. There is a line of demarcation at the base of the great toe with the swelling and ulcer region in the left foot. As far as the right foot is concerned, there was no deformity apart from the clawing of toes. There was loss of arches. The metatarsal heads were prominent along with the extensor tendons. In the left foot, we have found two ulcers. The first one was the larger one, that is a 3x2 centimeter, that is present on the plantar and dorsal aspect of the left great toe. The probe test was positive. The ulcer grading was University of Texas grade 3D. There was granulation tissue in the ulcer. There was another smaller ulcer. The measurement was 1x1 centimeter on the dorsal aspect of the left great toe. The grading was University of Texas grade 1C. The right foot had, yes sir.
Sorry, this patient has gangrene, you said.
Sir, this patient had there was a blackish discoloration, but,
yeah, so there is no gangrene, right?
There is no gangrene, sir, at the time of admission. Sir.
Okay, please go ahead.
There was no ulcers in the right foot. In the left foot, there were dystrophic nails. The peripheral pulses were not palpable. The 10-gram monofilament test was sensible in 3 out of 5 areas, as the grade 2 area could not be examined. The vibration sensation was diminished. The ankle jerk was diminished. But as in the right foot, the distal pulses, including the arteria dorsalis pedis and posterior tibial artery, were feeble. The monofilament tested 4/6. The vibration sensation was diminished, and as well as the ankle jerk.
When you talk about dystrophic nails, you need to be very specific because it's a very broad terminology. So, besides when you talk about dystrophy, the color, the extent of nail involvement, you know why it's important? From a therapeutic perspective, why is it important?
Sir, we can...
is there nail bed involvement also when you talk about dystrophy? So you should mention all this. What's the reason it's important?
It could indicate a fungal infection.
It could.
Yes.
And also you should describe it because the extent of fungal infection.
Yes.
How do you treat a fungal infection on the nails? Can I ask the next person? Dr. Pooja?
Yes, sir. Question is, sir?
How do you treat a fungal infection on the nails? Aruna, how do you treat a fungal infection on the nails?
So fluconazole is given, and duration is for longer duration. It is, sir. Some 6 months it is, sir.
You give everybody oral fluconazole? Or do you give something else? Suppose it's a mild dystrophy which is involving only the superficial part of the nail. What will you give? What are the other topical agents that can be given for nail infections?
Clotrimazole can be given, sir.
Clotrimazole on the nails?
Not on the nails.
Anything else? Anything else on the nails? What are the agents which can be used on the nails? This is an important, very straightforward. I'm not going to tell you the answer. Please
topical terbinafine is used at times.
Okay, good. So terbinafine can be utilized, right? So it's only when it's more severe and it's involving the nail bed, then we should think about using antifungal agents. But in case of extensive dystrophy, you may need to take off the nail, clean the entire nail bed, and then use antifungal agents. Right. Okay, keep going.
These are the clinical images of the patient, as we can see.
No, Moonam, you go back.
Okay, sir.
Previous slide. Yeah, you just try what you see. Once again, very briefly.
Sir, in this picture, we can see the left foot, the tip of the great toe. There is the lesion, the ulcer. The first one is a bigger ulcer at the tip of the great toe, and the second one is the smaller ulcer on the dorsum of the great toe. There is also the surrounding blackening of the skin with a line of demarcation, and both the feet, we can see there is obvious drying of the skin with cracks and fissures and callosities. We can also see the hair loss and loss of perspiration, and we can see the deformities in the form of clawing of the toes.
So, could you tell us the cause of clawing of the toes?
Yes, sir. In neuropathic foot, due to atrophy of the distal small muscle, particularly the extensor muscles, and due to the overaction of the flexor tendons, there is flexion of the metatarsophalangeal proximal and distal interphalangeal, all the joints. So that leads to clawing of the toes.
Sorry, come again.
The flexion of
the flexor tendons, yes, that
and atrophy and weakness of the extensor tendons due to motor neuropathy.
Then how does clawing occur? What is the description?
Sir, clawing means there is flexion of the metatarsophalangeal, proximal and distal interphalangeal.
So here you see the metatarsophalangeal joints are flexed in this patient. What about the others? So Pooja? Let's go down the list. Aruna?
Hammer toe, sir. There is a...
No, so what the deformity that you see here? The metatarsophalangeal joints, Monam says they are flexed. Do you agree or you don't?
Sir, for me it is not like a flexed, sir, MTP joint, but there it would appreciate the... Sir?
Yeah, right. The interphalangeal joints, they are flexed, clearly.
Sir.
But what about the metatarsophalangeal?
It appears to be normal, sir. Here there is only interphalangeal joint flexion I could appreciate in this image.
Right. So flexion is not, you cannot appreciate, right?
Sir.
And what other changes do you see here on the feet?
Dryness of the feet with high...
No, whatever, beyond what he has already described. Would you like to comment on the veins?
Yes, sir. Prominent veins are seen here on the right foot. I can see the prominent veins are present. On the...
Even behind the malleolus, I think. If you look a little closer.
Sir.
And yeah, in front of the malleolus also. So what's the explanation? So what's the explanation in this context? So no doubt that the patient has venous prominence. So what causes venous prominence?
Opening of the AV shunts that will...
Yeah, and then what happens to the peripheral pulses? If you have opening up of the AV shunts.
Generally, there will be more palpable, sir, if there is this opening.
Yeah, but while describing the pulses, Monam told us that the pulses are feeble. So I was a little, again, surprised, you know. So with such a significant venous prominence, you would expect the pulses to be either normal or a little bounding, right? Okay, Dr. Nihal, you have anything on this? Or
yeah, in fact, this is a really amazing photograph because there's a wealth of information here. What I'd like to point out is look at the first metatarsal joint on the left-hand side and also look at the skin around that area. Compare it with the right metatarsal joint. You can see proximally in the big toe, there's a skin crease that is totally absent in the left big toe. There's no skin crease there, right? Proximally. Whereas there's a skin crease present over here on the proximal end of the right big toe. This is actually a sausage toe, if you look at it. Definitely looks as though it's gone through recurrent episodes of inflammation and darkening of the skin over here. The other thing which I'd like to point out is go to the malleoli, the medial malleoli of the right and the left side and compare the two. They're very different. The right medial malleolus looks prominent. Of course, this is a photograph and not a three-dimensional view. And of course, there may be the way the photograph has been taken, maybe have been taken more from the left-hand side with the photographer from the left-hand side. But definitely there's a prominence of the right medial malleolus when compared to the left. So where do you get a prominent malleolus. Especially, in fact, when you examine, you should look from the back of the patient and not the front. When does the medial malleolus become prominent? What condition? What does it indicate?
Charcot.
Yeah, why? How? What's the mechanism? Why does it happen?
Subluxation of this talonavicular joint, sir. That
Correct. So descent of the talonavicular complex may lead to more prominence of the medial malleolus. So there's a suggestion here. I'm not saying that we can be 100% sure, but it looks like that. Okay. Thank you.
Shotinath sir, you're muted.
So yeah, in the context of the sausage toe, which this patient clearly has, so what should come to your mind? Monam, if you see a sausage toe like this one, it tells you something. What is that? Aruna? Okay, Venkat?
Any infection?
Yeah, something beyond that. So sausage toe, or this is pseudogigantism, right? So it tells you what? Which this patient invariably has. Whenever you see a sausage toe, you are almost certain that this patient has underlying osteomyelitis.
Osteomyelitis.
As simple as that, right? And before Monam takes us further, I would like to say that this photograph has not been properly taken. So all of you be aware of this. When you take a photograph of the foot, you should take it from above and go as close to the foot as possible. You can see there is significant foreshortening. In the previous picture, Dr. Nihal was discussing about the malleolus. Here you can hardly see the malleolus. No, go to the next slide. Yeah. So there is such a severe foreshortening due to your wrong technique of taking the photograph. You wanted to highlight the great toe, that I understand, or the forefoot. But the hind foot, the mid-tarsal area and the heel, they appear severely foreshortened because of the wrong technique. So be careful about that. Okay. And maybe we can move ahead now, Dr. Nihal. Can we move ahead? We have.
Please go ahead.
Yeah. Okay. Please go ahead.
The final summary is 60-year-old businessman from Kolkata who is a known case of type 2 diabetes mellitus for 10 years on oral anti-diabetic agents, presented with a non-traumatic ulcer on his great toe since last 3 months with foul smelling discharge. He also complains of tingling and numbness in both his legs below knee with burning sensation and slippage of chappals from both his feet. He gives no history suggestive of nephropathy, retinopathy or macrovascular complications. On general survey, he is found to be overweight, hypertensive, having acanthosis nigricans.
Monam, after examination, you are now convinced, I believe, that the patient has
autonomic neuropathy.
So
yes, sir. Yes, sir. I did not mention it.
You need to revise.
Yes, sir. On local examination, both the feet are found to have callus, cracks, fissures, dry skin, hair loss, and deformity in the form of clawing, sausage digits, and loss of arches. An ulcer of 3 by 2 centimeter was found on the plantar and dorsal aspect of the left great toe with probe test positivity, Texas grade 3D with granulation tissue, and another 1 by 1 centimeter ulcer on the dorsal aspect of the great toe with Texas grade 1D. Peripheral pulses were not palpable on the left side, but the 10-gram monofilament test and the ankle jerk was lost in both the sides.
Please proceed.
Okay. Coming to the Coming to the investigation, these are the investigation parameters. So should I read it out or?
No, just tell us the significant findings.
Okay, sir. Complete blood count, he has a hemoglobin of 10.9. Total leukocyte count was normal with a neutrophil of 66%. His routine urine examination, sugar was 2 plus.
This hemoglobin, does it ring a bell?
Yes, sir. He is having anemia. That can be due to associated underlying nephropathy that we might have missed, sir, in the examination and history.
You have checked the urine also. So now, do you agree that this patient has nephropathy? The urine report.
Albumin is also yes. Albumin is also 1 plus, sir.
So is that nephropathy or not?
But it could be non-albuminuric diabetic kidney disease.
No, this patient has albuminuria. 1 plus albumin is, you don't think that is significant?
Yes, sir. Yes.
Okay, so now in this background, what could be the possible causes of anemia?
Sir, any chronic infection, anemia of chronic inflammation, diabetic nephropathy, iron deficiency due to dietary causes.
Any reason or long-standing diabetic could be having iron deficiency?
So due to diabetic gastropathy,
Yes.
malabsorption.
Malabsorption of what?
So iron from the duodenum.
Any other causes of anemia? So, okay.
Metformin.
Right. So how does metformin cause anemia?
So by causing vitamin B12 deficiency.
So how can you rule that out here with the hemogram?
Sir, we have to check for the MCV, MCH and check whether it's macrocytic anemia or not.
So there is no such comment.
Yes, sir.
Can autonomic neuropathy cause anemia, Pooja?
Gastroparesis, sir.
Any other mechanism? Venkat?
I'm not sure, sir.
Okay. Aruna then?
Because of this decreased erythropoietin response.
Great. So you people are excellent. Good. So Monam, proceed.
Okay, sir. So urine albumin.
Why does decreased erythropoietin response occur, Aruna?
Sir, sorry, sir.
Why does decreased erythropoietin response occur? Due to what mechanism?
Sir, in anemia, this in advanced renal failure, this will be lost.
Not advanced renal failure. Dr. Satynath is mentioning, even without advanced renal failure, you can get
Yes, sir.
a decrease. And you mentioned what is the reason for that? Where is erythropoietin? Where is the precursor of erythropoietin produced? So you know the answer. What is the precursor of erythropoietin? Renal erythropoietic factor, right? So where is it produced? Source. Who's next? Nitin.
No idea, sir.
Juxtaglomerular apparatus, right? So you have sympathetics which go there, and you have autonomic dysfunction, the production of renal erythropoietic factor is reduced.
Okay.
Dr. Nihal, can you proceed? Moonam, are you there?
Yes, sir. Yes, sir.
Yeah.
Sir, can I proceed, sir?
Yeah. But then again, sorry, your urine ACR is 69 and albumin is 1+. So at what level of ACR do you get 1+ albumin?
Ten to 100. 10 to 100.
Urine albumin 1+ means this is a dipstick positive proteinuria, right?
Yes.
10 to 100.
100 is detectable? I'm not aware. Anybody else? So, Venkat?
Sir, it is at least 200, sir.
Okay, Anirudh?
100 to 200.
No, I think Venkat is right. So at least 200. Usually it's more than 300. Only then your dipstick becomes positive. Correct me if I'm wrong. And so your albumin, routine test albumin is 1+, but your ACR is 69, which is in the range of microalbuminuria, way below 200. Something wrong here, unless Moonam tells us that a decimal has been displaced to the left, it's 693, then it's okay. Otherwise, Dr. Nihal, what do you think?
I agree with you, Dr. Satyanath.
So something wrong here.
Maunam,
Okay,
I give you a hypothetical situation. This patient has had what you think is osteomyelitis now for almost a year. His A1C was 6.5 for that 1 year duration. His creatinine was 1 a year back. Is currently 1.6. And the albumin is now 3+. What should you think about?
Sir, ACR has increased. Albumin has increased.
Albumin has increased. Creatinine has worsened. A1C has been the same. Has been actually under good control for 1 year. And the patient has had osteomyelitis.
He might be developing amyloidosis, renal amyloidosis due to chronic inflammation.
Yeah. So this is a very often a condition which we should think about in patients who have underlying chronic osteomyelitis, which may be missed, which may overlap with diabetic glomerulopathies.
Okay, sir. In the renal function test, his eGFR was 65.3. LFT was within normal limits. Lipid profile, LDL cholesterol 110, HDL cholesterol 45, triglyceride 325. Fasting plasma glucose 208, postprandial plasma glucose 289, hemoglobin A1C 8.9%. Sodium potassium was normal. Duplex Doppler of lower limb bilateral shows monophasic flow in the left anterior tibial, posterior tibial, and arteria dorsalis pedis. Rest all the flow were found to be triphasic. There was evidence of bilateral atherosclerotic disease. Small hypoechoic plaque in both common femoral artery. The ankle brachial index was found to be 0.6 on the left side and 0.8 on the right side.
I think we are getting a red signal from the tech support. So maybe you have to be quick. How much time are we left with?
So we have 6 more minutes.
6 minutes. Thank you, Shomik. So quickly, can we go to the X-ray?
Yes, sir. Yes, sir.
Yeah, just describe very briefly. What do you see?
Sir, this is the X-ray of the left foot of the patient, which shows the evidence of bony erosion in the left great toe, the distal phalanx, associated with the increased marrow translucency and there is also evidence of new bone formation around the lesion.
Okay, so the
Can
diagnosis.
we talk about marrow translucency on an X-ray? Is that appropriate?
Sir, actually, this medullary cavity, they appear unduly more radiolucent actually. Actually, sir, it is more evident, evident on MRI actually.
Yeah.
Yes.
Sure. Okay, on MRI, on which imaging? T1 or T2 weighted?
Sir, T2 weighted with T2 particularly.
So normally a T2 weight would look a little darker, and you'll have patchy white areas. There's a loss in marrow.
Tech support, can you please mute yourself? Tech support.
Hello.
Okay, Monam.
Hello, sir. Yes.
What else do you see on the X-ray?
Yes, sir, there is also calcified vessels that I could see.
Yeah.
In between first and second metatarsals.
Calcified vessels are there everywhere actually.
Yes,
Looks
yes,
like
sir.
an angiogram. So how do you now interpret your ABI given the fact that the patient has vascular calcification?
Sir, it should be more, we have to recheck it because it should be more than 1.3.
So this is may have been falsely lowered.
Falsely lowered, sir.
Then how do you obviate that? Is there any other technique by which you can get the actual, the pressure in the foot, blood pressure beyond ABI?
Yes, sir. We can measure, sir, ankle systolic pressure. We can measure toe pressure.
No,
and
can measure means ankle systolic pressure. With ankle systolic pressure, you can remove the effect of this vascular calcification.
No, sir. No, sir.
So how can you eliminate that as a confounder?
No, sir. We can measure, sir, toe pressure and transcutaneous oxygen pressure in the toe region.
Okay, so do you have the facilities?
No, sir. I actually not have.
You can send the patient over to us. We have both, so we can check them for you and give you the information. Okay. Dr. Nihal?
Yeah, I mean, I
We have 3 minutes left actually.
Okay. So what's your next step in the evaluation over here? Have you done anything further?
So we have planned for MRI of the foot, sir.
You need
and send the
MRI,
culture sensitivity and start it on.
Obvious that there's osteomyelitis. You don't need an MRI. Okay, you can take a culture sensitivity. Why do you take a culture sensitivity? What's the reason?
So to guide us regarding the appropriate choice of antibiotics.
Commonest organisms which are over here.
So usually it's polymicrobial. Among gram-positive, the commonest organisms are Staphylococcus and Streptococcus. In gram-negative, we found E. coli and Pseudomonas Bacillaria. Yes, sir. And an anaerobe bacteroids are found frequently in our...
Which staff?
Sir, audience, sir.
Any other staff can be found?
Sorry, sir?
Any other form of staff?
Epidermidis. Sir, epidermidis.
Sure. This patient has been admitted to hospital before?
No, sir. He was treated on outdoor basis, sir, before admission.
Sure. Have you taken cultures?
Yes, sir. The cultures were sent, sir.
Suppose this grows MRSA, what would you do?
Yeah.
Sir, we will try to give vancomycin or add vancomycin, linezolid.
Sorry, I lost you there.
Sir, we will add vancomycin or linezolid, sir, to give MRSA coverage.
Will you use vancomycin or something else? You're basically managing oral antibiotics. So linolazid, yes.
Linezolid, sir.
With what?
Sir, with an anaerobic coverage like metronidazole.
Okay. Rifampicin is commonly utilized along with
Okay, sir.
linezolid, right?
Okay, sir. Okay.
Sorry, I can't turn my video on. Something wrong. So how would you manage this patient now? What would you do next? Besides antibiotic cover, even if it's grown this organism, what's your sequential plan?
So surgical debridement, proper antibiotic therapy, offloading of the foot, and
What kind of offloading are you going to give over here? Anything specific?
sir, firstly, in the sign of acute inflammation, we will try to immobilize the foot, and then we will subsequently we will advise him a customized footwear.
Sorry, just repeat what you said.
Sir, in the stage of acute inflammation, we will try to immobilize the foot by providing an immobilizing measure like a total contact cast, and afterwards we will advise.
Do you need a total contact cast? It's only the big toe which is involved. You really need a big total contact cast in this thing. That's an overkill. You only have involvement of the big toe.
Only say toe cast. Only say toe cast.
You don't need a cast. See, I think what you require over here in this particular patient is ordinary microcellular rubber footwear.
Yes, sir.
You don't need to totally immobilize the toe for any reason at this point of time. Dr. Satyanath?
Yeah. We are nearing the end of this session. So, Dr. Nihal, would you like to have any final comments on their performance as a group, or we leave it here?
I think perhaps a few things I'd like to highlight. Dietary recall is immensely important when you, go through your long case as well. Foot, of course, by and large, you need to know everything about the foot. We haven't really covered much on Charcot's in this particular class. We haven't done that much on offloading, but these are also very important issues. And of course, the final question I would like to ask over here is, how would you like to consider amputation in this particular patient? You have given a trial of antibiotics for 6 months. Would you consider would you consider amputation?
Yes.
Any reason why you would not consider amputation in this patient?
Right. My thoughts exactly. So, Monam, how do you respond? Can you salvage the great toe? That's the question.
Sir, as we have found the osteomyelitis, we will first give IV antibiotics for 6 weeks. If there is still poor response or no recovery at all, then we will try to, we'll have to go for amputation of the affected parts.
How is it vitally important to prevent amputation of the great toe? That's what Dr. Nihal wants to know from you.
One is intravenous antibiotics are required only if the surrounding tissue is inflamed. If you have exclusive bony involvement, you don't need it. The second thing over here is, like Dr. Satyanath was also suggesting, as far as possible, do not take off the great toe, because it will cause a total imbalance of your foot. It's going to be very difficult later on to offload. Once you take off the big toe, then the pressure points are going to change their dynamics. You're going to put a lot of pressure on the stump of the great toe and also on the lateral aspects of the foot. And it will be an ongoing problem for a very long time to come. If you have to, yes, but you would like to preserve as much of distal bone as much as possible.
And if at
all in this patient, you'd like to just remove the distal phalanx. I'll close with that. I think we're run out of time. Dr. Satyanath, some final comments from you.
I completely agree with you. I would only like the participants to go through the excellent papers on the impact of rifampicin in a scenario like this, which Dr. Nihal has already suggested. So with this, no further comments. We hand over the session to Dr. Shomi Goswami for the final call.
Thank you. Our heartfelt thanks to both our examiners for taking us wonderfully through that case on diabetes, and of course for providing their insights, their thoughts, their pearls of wisdom as well. We straight away move over to case number 5, and to present case number 5, we have Dr. Shinjon Patro, who is a postdoctoral trainee at the Department of Endocrinology at All India Institute of Medical Sciences, Jodhpur. And as examiners, as usual, our examiners need no introduction. They are very popular. They are very eminent. We have Professor S.K. Singh from Benares Hindu University, and we have Professor Ganapati Bantwal from St. John's Medical College, Bengaluru. The names of the group participants will soon be there in the chat box for our examiners to use to ask questions to members of the group. Over to Dr. Shinjon Patro and the examiners to take us through case presentation 5.
Dr. Swami, good morning.
Good morning, sir. Good morning.
Greetings from Varanasi. I hope the students must have learned many things, and further we would add to their knowledge.
Sir. Yes, sir.
The case presentation 5 by Dr. Shinjon Patra. Over to Dr. Shinjon Patra.
Okay.
Good morning.
Sir, good morning. Are the slides visible and I am audible?
Yes. Yes.
Okay. So good morning all respected faculties and my dear colleagues. So I am Dr. Shinjan from AIMS Jodhpur. So I will be starting with my case presentation. So this case is about a 15-year, 7-month-old female who is a resident of Jodhpur and a student of class 11. So she was admitted in our AIMS at 8th of December and subsequently discharged on 13th of December. Her chief complaints were short stature and weight gain. So just to detail about these two chief complaints. About the short stature, she was apparently asymptomatic 4 years back when she met a road traffic accident and fracture followed by immobilization. That time regarding the evaluation to an orthopedician and subsequently to a physician and endocrinologist, she was noticed to be short for age. But there was no such complaints from the family members. And that time she was advised workup for the short stature. The previous height SDS, however, was not documented that time. With the evaluation at that time, we don't have all the documents properly, but she was diagnosed to have an isolated GH deficiency, which was not associated with any syndromic features. So she received a recombinant growth hormone from February 2018 to June 2018, about around 4 to 5 months, of a dose of about 1.5 milligram day, which is around 0.35 milligram per kg per weight, which she stopped herself with her parents after not noting any improvement in the height. Regarding the weight gain, she had a history of weight gain for last 4 to 5 years, but which was very prominent and excessive for the last 2 years. And according to her, she weighed around 35 kgs 2 years back, which has now increased up to 44 kgs, which is mostly increasing adipose, which is mostly seen in the abdomen region. However, there is no definite drug history. Especially we inquired about any kind of herbal steroids or any topical drugs in last 4 or 5 years. Just one important growth hormone history on that period, but other than that, there is no long-term drug history, and also there is no definite change in the lifestyle. With these chief complaints, also she complained of a facial puffiness.
Dr. Singhan, can I interrupt here?
Yes, sir.
Why? With the chief complaints, which you have already elaborated, what comes to somebody's mind with these features before we go for and have some leading questions to find out the exact etiology? So what comes to your mind? The short stature, age of 6 years or 7 years. By age of 11, the boy has presented. So 6 years, 7 years age, short stature and weight gain. What comes to your mind?
Sir, mostly the endocrinological causes
You just enlist the possibilities.
Yes, sir. Sir, we will.
B, C.
So we will think about the growth hormone. First is about the hypothyroidism. Then we'll think about the Cushing's syndrome. We can thought about isolated growth hormone deficiencies. Pseudo hypoparathyroidism you also can think. And
how do you explain weight gain with isolated growth hormone deficiency?
So typically those patients of isolated growth hormone deficiency don't have much of a significant weight gain, but still
that's why I'm asking, putting them to the first you said hypothyroidism, the Cushing, pseudo hypopara. What else?
Then, sir, also we can think about some obesity syndromes like Prader-Willi syndrome or Bardet-Biedl syndromes. Those can also present. Also, if we think hypopituitarism, where we have a multiple pituitary hormone deficiencies, including thyroid deficiency.
Specific in hypopituitarism with weight gain? Which condition of hypopituitarism can present with weight gain? Usually hypopit should not have weight gain or obesity. So which condition with associated hypopituitarism would lead to weight gain?
So like
also come to your mind.
Right, so hypopituitarism due to any cellular mass like craniopharyngioma.
Cellular mass, a possibility of cellular mass.
Right.
And in this age group, though it is not very common in the first decade, but what would be the cellular mass most likely associated with weight gain and growth failure?
So craniopharyngioma in this age group maybe a...
Now go ahead, please. Yes.
Oh, thank you, sir. Associated with the chief complaints, the other complaints...
Just one question. What is the reason for weight gain with the craniopharyngioma? What could be the reason?
Sir...
Yeah, I didn't ask. I thought you knew it.
Okay.
You should tell the cause. Weight gain.
Okay, you find out.
Lesion in the hypothalamic area, a lesion encroaching hypothalamus.
Correct.
Sir,
ventromedial nucleus
with the feeding center and the satiety center are there. So it will lead to hyperphagia and leads to the weight gain.
Okay, fine.
People say they can have height gain without growth hormone.
So what do you mean by growth without growth hormone syndrome? What is growth without growth hormone syndrome? And what are the markers which has been found which helps in that? Or what hormonal things help in that?
I'm not very sure about that, sir. Okay. Shall I go ahead, sir?
Yeah. Okay.
Anyone can answer the question? Which
Roshan group?
Yeah, the whole group.
Sir, due to associated hypogonadism, there is in craniopharyngioma.
No.
Age of 11, would you suspect hypogonadism?
No, sir.
Mediated pathway have been implicated in it.
Yeah.
Go ahead.
Go ahead.
Sir, associated with the chief complaint, she was also having the facial puffiness, increased facial hair growth and acne. She noticed purplish marks in the abdomen and thighs and lower leg swelling. Also, she complains about the easy bruisability typically when she underwent any sampling for any purposes in last couple of years. Mood changes, she had complained associated with mostly anxiety and depression, which she mostly accounted for the academics. Also, she is having non-specific polyarthralgia, bony pain, and she had suffered from a recurrent renal colic due to renal calculi 3 episodes were there, and for the last episodes she has underwent a DJ stent, which was around 6 months back. About all these
what about the adiposity characteristics you expect?
Sir, about the adiposity in here, which this complaint, she typically talks about the more of a fat depositions in the abdomen, more increase in the waist circumference. This she was.
Now, since she is a young child, I mean young person, so what do you expect? What is the usual character?
So usual character, like from the patient's side, she will more complaining of a tightening of the cloths, especially in the abdomen areas, and also
the question is here: if there is a weight gain or fat deposition in child or in adult due to excess of the glucocorticoid, so what would be the difference in the two? That
exactly. Yes, sir.
Sir,
just answer that way.
More of a centripetal.
Is there any difference or it is almost same?
Sir, abdominal obesity will more be marked in the adult population compared to the younger populations.
Younger population, what is the characteristic?
So they more have a fat depositions in the areas of the upper back areas or in the
Roshan group.
Generalized obesity, sir.
Generalized obesity.
Now, can anyone give explanation why
low mental fat with 11 beta HSD1 inhibitions? Generally, mental fat has 11 beta HSD1, sir, which will be more active. In Cushing syndrome, it will be in adults, like it causes overactivation and deposition of the abdominal obesity, whereas it won't be seen in due to lesser mental fat, it won't be seen in children, and there is tendency towards generalized obesity.
So that is one plausible explanation, that beta HSD. But other than that, any other explanation can think of? That has not been actually demonstrated in experimental models or any clinical model that there is a big difference. But any other explanation that might be in support of this?
No, sir, I don't know, sir.
They have more anabolic hormone?
Yes. So they're in the growing age group, no? So 11 means peripubertal, 12, 13 nearing puberty. So more anabolic hormones are also there. That is one. And secondly, what is the other reason? They're all hyperactive. These children can be active. And as you know, Cushing's stigmata can be overcome with good exercise or intense exercise.
Yeah.
Okay. And you spoke about the fractures there. What would you have seen in that fracture? Say you see the old X-ray. You want to look into specifically anything in the X-rays?
Sir, in the X-rays, we could have looked for any the pseudo fractures or any just a cortical break in the bones, and also we should have. There was no such history of fracture, and also we should take the vertebra. We should take the
anything else.
Callus formation.
Right.
Better you focus first on the fracture. The question was, if you see a fracture, what else you would like to see in fracture? State.
So yes, the callus formation says we can look for that.
So callus is always there in any fracture. If there is a fracture with time, there would be a callus formation.
No, sir. It's typically can be seen in these group of patients who are on maybe on exogenous steroids, or if having an endogenous hypercortisolism. Those patients can.
You said about the callus. So callus formation always is there in so any difference in the callus you want to add? Anyone else?
Ahmad?
on the growth. Yes.
The callus formation in patient with Cushing's syndrome is exuberant. They have very high callus formation, sir. That is very specific for Cushing syndrome. So that can be looked in the X-rays, previous X-rays.
Right. Okay, you also spoke that the patient received growth hormone therapy and did not respond. I just want to know what is the effect of steroid on growth hormone dynamics? Acutely what happens and chronically what happens?
Sir, what can happen if the...
Acutely what happens? Acutely means 24 hours. Chronically what happens?
So in chronically, it can suppresses the growth hormone levels. So if the patient can having a growth hormone, even if the patient is having a growth hormone excess, it can be fast masked by the chronic exposure of the glucocorticoids, which is in Cushing's.
Acutely?
But and acutely, in acute administration of the steroids, it can have a positive effect on the growth hormone. That is the opposite effect mostly.
Yeah, acutely for 24 hours, you can have an increase in the GH also. Okay, fine.
So, shall I move ahead, sir?
Yes.
About her complaints, she had about the Parply stria. According to her, it varied between time to time, around for last 2 to 3 years. But for the last around 6 months to 1 year, she was complaining the Parply stria appearance has been quite consistent. But before that, it quite varied. Also, the facial puffiness, it also varied initially for the last 3-4 years, but that has also settled down in the last 6 months. About the negative history, as I was talking about the...
What is the characteristic of the facial puffiness? When do you say actually any obese people also will have round faces? So how do you differentiate whether it is Cushing's related or versus a generalized obesity which produces a round faces?
So more of a the facial puffiness, more of a symmetrical, and throughout the whole face is in the found in the Cushing syndrome with a steroid effect.
Anybody else can answer?
Sir, Dr. Anish here. From the front, if we look at the patient's face, the ears may not be visible or may be hidden by the amount of cheek fat present on both the sides. That could be an indicator.
Correct. Yes, that's right.
Thank you, sir.
What's the cause for that renal calculi? So is it common? What is the reason? Renal calculi.
Sir, in hypercortisolism, there is a predominance of the hypercalciuria, which can cause a renal calculi. Other than that,
how does that hypercalciuria occur?
Sir, about the hypercalciuria mostly happens with the increasing cortisol exposure. The renal calcium handling, the renal calcium absorption is getting decreased.
Why?
In the distal convoluted tubule. Sir, mostly
secondary hyperparathyroidism.
Right, correct. Yeah. Continue, please.
And associated with that, metabolic syndrome due to the steroid exposure in the Cushing syndrome, they can have other metabolic stone formations due to cystinuria and this thing. So they can have that causes.
Metabolic syndrome moment you find, what will you suspect? What stone can be common in them?
Sir,
when somebody complains of metabolic syndrome, this stone, what is that?
So oxalate stones and cystinuria.
Metabolic syndrome, what are the components of metabolic syndrome?
Uric acid.
Yes, very good. Yeah. Uric acid, no? That's a hyperuricemia is common, so they can have uric acid stones also. Yes.
Along with that, negative history we have taken about the possible causes of the short stature and the increased weight. We have ruled out any history of any goiter, mental slowing, intellectual disability, or symptoms of hypothyroidism. Also, we have talked about the adrenal insufficiency associated with the hypopituitarism, about the recurrent hyponatremic episodes, weakness, or weight loss. We have talked about the pseudo-hypoparathyroidism, so we have ruled out any dysmorphic features related to Albright's hereditary dystrophy, and also isolated growth hormone deficiencies as a secondary causes. Lower down the causes, we have also typically the phases we have ruled out about the negative history. So this is as the patient was very educated and she had her all the photographs for the last 4 or 5 years, it was easier for us to appreciate the facial as well as the body changes for the last about 4 to 5 years. So these were the serial photographs taken by her. So this has helped immensely for detecting the gradual physical changes and the face and the body. And currently, patient looks like this. This is the current picture of the patients in our admission time. So about the birth and the other history, like the birth history, she was born out of a non-consanguineous marriage without any prolonged jaundice, hypoglycemia, hypoxic episodes, and seizure activities. She attained language and motor milestones at appropriate ages. About the personal history, she hasn't attained menarche, but she's having adequate scholastic performance in the school so far. And family history, there is no similar family illnesses, no endocrine, no similar major endocrine illnesses or any syndromic illnesses in the family.
Just 1 second.
Yes.
You spoke about adequate scholastic performance. You expect it to deteriorate, or you expect it to be good or bad, or what? How is it?
Serena, this younger group of patients where we are suspecting Cushing's, we don't expect much decrease in the scholastic performance. It may be higher than, she may be the best in the class, maybe the topper as well. So it should, we are not expecting much of a deterioration.
Yeah, so they are all overachievers.
Yes. Regarding the disease-specific negative history we had asked, we asked about any fragility fractures or any low trauma fractures.
Fragility fracture? Define fragility fracture.
So the fragility fracture is where it's basically a low trauma fracture where the patient can fall from less than or equal to her standing height if she attained fracture with that. So that we call mostly a fragility fracture.
What are the other examples? So fall from a standing height and you get a fracture. Agreed. What are the other examples? You sit in a chair, you fall. Is that a fragility fracture? Suppose you are running and you get fractured. Do you call it as a fragility fracture?
Sir, it is mostly a low trauma fracture. So in a running and get a fracture, so there is a high energy is there. So that we can't take it as a fragility fracture.
If you're running at a speed at less than a run, so a brisk walk, then you get a fracture, then you call it as a fragility fracture?
No, sir, that is not the fragility fracture.
Yeah, Ahmad?
I'm not sure.
Aruna?
Sir, not sure.
Okay, and so if you are decelerating at a speed less than a run, that's also a fragility fracture. Okay.
Then associated other negative histories which I have talked about, it's the light has got. Anyway, the other history which has gone is other histories which I have taken is about the acute onset back pain, proximal myopathy, mostly difficulty in going into the stairs. About the virilizations, any history of hyperpigmentation, especially in the hands and knuckles, known diabetes or known hypertensive history on medications, any vision disturbances of late, any gait abnormalities or any abdominal swelling or mass or any cutaneous fungal infections. These are all the negative history we have asked, which came as and negatives.
Just hold on.
Yes, sir.
So many negative history. Do you expect how common is to see in such patients the vision disturbances? How common is to see the abdominal mass from the history?
Sir, about the vision disturbances, if we think about the exogenous steroids use, especially with the exogenous Cushing's, the patients have predominantly having a vision disturbances with increased intraocular pressures or even with the cataractus changes.
Exogenous steroid intake, not in this case which you are dealing with.
Sir, yes, we don't have a definite drug history.
We don't have. Right.
Yes. And sir, about the abdominal mass, yes, in this young group of patients, as we are suspecting a Cushing syndrome, in a ACTH independent causes, we have important causes of ACTH independent macronodular adrenal hyperplasia. In those cases, we may got a abdominal masses, or she may complain of abdominal pain or abdominal complaints. So that was the mostly idea behind that.
Just between the two, the bilateral, you said nodular hyperplasia, you will feel masses. You will not.
Sir.
Never. We'll come to that also.
Okay.
What type of changes are there in bilateral adrenal hyperplasia? If it is ACC, maybe sometimes you can feel a mass, but it's very, very uncommon to see mass, particularly in Cushing when they have put on so much of body weight and there is abdominal fat. It's difficult. In history, it is difficult to find out the mass. Right?
Okay, sir.
Why there is a cutaneous fungus infection common in these? And you have asked the history also.
Sir, the long-term exposure of hypercortisolism leads to defect in the innate immunity. So the patients typically prone to the fungal infections like the pityriasis or the tinea infections. So those things can be also an associated complaints in this.
Okay, good.
You spoke on the eye. I'm just coming back to Dr. Eskasin. You told there's an increase in intraocular pressure and you may get an eye changes, you told, no? Visual thing. What visual disturbance you get when you have an increased intraocular pressure?
Sir, in intraocular patients, the visual blurring, maybe the occasional visual blurring. That can be the...
Aruna? So what do you get if you suppose you have a glaucoma or increased ICT? What is the
vision? Acute glaucoma can compromise with vision, sir.
Anything else? Yeah, you are right. If it is not acute.
Sir, increased blind spot and
Neovascular. It's the increase in the size of the blind spot. That's what you get actually. That's right. And what is the reason for diabetes? Why do you get diabetes? What is the pathogenesis?
Gluconeogenesis.
Okay, one. Then?
There is increased gluconeogenesis, sir.
Okay.
There is increased hepatic glucose output and PepCK activity, phosphoenol pyruvate kinase, this enzyme that can also lead to increased gluconeogenesis, sir. PepCK activity. Increased resistance, insulin resistance, sir.
How is the insulin resistance mediated by glucocorticoid?
So due to increased lipolysis.
Increased lipolysis.
Increased lipolysis is a different thing. We are talking about insulin resistance first. Insulin resistance means the resistance could be level of?
Sir, it can also be at the level of the receptors at well, at the level of the insulin receptor.
The organ wise?
So muscle and adipose tissue, sir.
Adipose tissue.
Adipose.
When you are saying that increased lipolysis, that doesn't explain the insulin resistance so generalized. So what is the mechanism of insulin resistance? Any molecular basis you remember?
Decreased GLUT4 expression, sir.
GLUT4 expression in the muscles. Okay. Yes. Any other?
So lipolysis causes increase in free fatty acids, which can contribute to insulin resistance. Free fatty acids can contribute to insulin resistance.
What are the lipid abnormalities seen in patients with Cushing? If you do lipid profile, what kind of lipid abnormality would be seen in?
So usually it's hypertriglyceridemia.
Hypertriglyceridemia and decreased LDL.
Right. So go ahead. Yes.
About then I will talk. We have taken the history regarding the etiology of this suspected Cushing syndrome. So we have ruled out about the any evidence of recurrent headache, vomiting, the cranial nerve palsy, or any temporal vision loss. Any acromegaloid features and galactulia were absent. Also, we have taken any history of any known malignancy or any known chest or respiratory symptoms. This we have taken as a negative history. And associated.
Why acromegaloid features?
Sir, mostly we have
yes, yeah.
Maybe we have got a pituitary macroadenoma which is co-secreting both of these hormones, and also we can have a Carney's complex. Which is a syndromic cause, which can have also.
If there is an excess of growth hormone in prepubertal child, what would be the presentation of excess of hormone?
Gigantism.
Yeah, but sir, initially, if the patient is having also co-secretions of cortisols, this can mask the features of the acromegaly. So maybe this gigantism or the growth increase may not be that prominent if the patient is having associated Cushing syndrome.
But at the same time,
but it won't be short stature also.
Yes, sir. Yes, sir.
Acromegalytism is not described in children, so that should not be there. Then you know the mechanism, even the growth hormone in excess doesn't have effect on the target tissue. So you will not have acromegalytism by any stretch of imagination. What you can have is the increase in
height.
Okay. So you should not use those terms. Otherwise, you see this case, how the case has been handled earlier. You have to be very, very specific now. Okay.
Okay, sir. Next, we have asked about the negative history regarding the familial syndrome. We specifically asked about any Carney's complex stigmata, about any mucocutaneous lesions or any cardiac complaints, or any diagnosis of breast and thyroid nodules before. And also we have asked about any McCune-Albright syndrome features. So these were not present in this particular patient. So now going into the examinations. In the general survey, the patient was conscious and cooperative. In the anthropometric measurement, she weighed 44 kgs, which is minus 0.61 STS. The height was 125 centimeter, which was minus 5.37 STS, and the BMI was 28.2 kg per meter square, which was 1.6 STS. About the vitals, the important to have taken is the pulse and blood pressure. The pulse was 96 per minute, regular, and the blood pressure in the left arm in the supine position was 140 by 74 millimeter of mercury. The systolic blood pressure was more than 99 percentile according to the height and age. The diastolic blood pressure, however, was between 50 to 75 percentile. About the other physical features in
the systolic blood pressure increase. So tell me the reason why do you get hypertension when you have?
Sir, in the chronic steroid exposure in the Cushing's, we can have a RAS system, renin-angiotensin activation. So it leads to increased aldosterone secretions, leading to vasoconstrictions. Also associated with that, the Cushing's having with the glucocorticoids, they have more of a water and salt retention. So that also leads to the hypertensions. These are the predominant causes leads to the hypertension.
Is this the predominant or something more?
Yes, salt and water retention more is because of glucocorticoid.
Sir, both the glucocorticoids and the mineralocorticoids, because the glucocorticoid has a mineralocorticoid-like action. So that
spillover effect.
That's yes, spillover.
Yeah. Any other reason?
Okay.
In
so
RAS
this
system,
increase
reactivity. How specific RAS system is affected in glucocorticoid axis? How this RAS is affected in glucocorticoid axis?
There is apparent mineralocorticoid axis.
Yeah, the mineralocorticoid is, so you said RAS is affected. How RAS is influenced when there is excess of glucocorticoid? RAS is renin.
So there
what
is
happens to renin in such patients?
low renin, low aldosterone.
Yeah, renin suppressed. So RAS, you mentioned RAS. RAS is not the correct answer. Is more mineralocorticoid axis, right?
And
What are
there
the
is
other
a permissive
regulators of
role of
renin?
on epinephrine.
What are the regulators of renin?
Sir, the regulators of renin is in the proximal tubule we have got if the low filtrations or the low sodium load.
Blood flow is 1, 2.
Blood flow, the sodium, and the sympathetic activities.
Potassium.
Any amount of potassium?
Yes.
What else?
What happens to potassium when there is a mineralocorticoid axis or glucocorticoid axis?
So it is can lead to hypokalemia.
But still we don't see hyperanemia in these patients. Though there is a stimulus for this. Other mechanism of blood pressure increase?
Insulin resistance.
Insulin resistance long term. It's not immediate.
There is a permissive action on epinephrine. Like
In endogenous Cushing's, because of the increased ACTH, there can be production of more deoxycortisone that leading to increased blood pressure. If it is ACTH dependent.
Activity or co-secretion or spillover, whatever. Other than that,
there is decrease in nitric oxides.
Nitric oxide, that's also.
Right.
Other than that, more endocrine approach, endocrine explanation than all this. Synthesis of catecholamines. Any clue from there?
There is increase of catecholamines from adrenal medulla and increased vasoreactivity to circulatory vasoconstrictors and increased secretion of pre-reninemic renin precursors from liver, sir.
The catecholamine synthesis is increased.
there is increased angiotensin and angiotensin also.
Why catecholamine synthesis increased? Precisely what happens?
PNMT enzymes.
PNMT.
PNMT.
PNMT. So you got it. So to explain, right? The next slide.
Sure. Okay. Sir, about the findings, other physical findings, she was typically having the moon faces with the acne and having the increased facial and body hairs with a modified Ferriman-Galloway score of 8/36, and she was having a bilateral pedal edema, bilateral leg swellings. Other positive findings, she was having a definite abdominal obesity, associated fullness in the dorsocervical and the supraclavicular region. She was having the wide purplish stria with ecchymotic patches mostly on the sampling sites. She had a grade 4 acanthosis nigricans. Sorry, there was twice ecchymotic patches. The ecchymotic patches were present in the significantly in the sampling sites. In the sexual maturity rating, she had a B3 and P3 according to Tanner staging. She had axillary hair present. However, there was no evidence of any virilization.
What do you mean by virilization? Evidence of virilization?
So virilization consists of some components like the male pattern here or the baldness, the deepening of the voice, breast atrophy. We can also get a clitoromegaly and increasing masculinity, increasing male torso. These can be in female patients.
Do you think there is no excess of androgen in this case?
Sir, yes.
No, virilization means no androgen exposure or no excess of androgen.
Sir, she has got a hirsutism, but the amount of androgen which needs, the higher amount of androgen which leads to the virilizing features, those are not.
Yeah, that's fine. But then there is an excess of androgen. The evidences are?
So evidences are like hirsutism and increased body hairs. These are the definite evidence of increased androgen exposure. And also the acne, yes, acne is also.
So you spoke about hirsutism, no? Tell me where she has those things.
So
you told 8 out of 36. So you just split it up and tell where all it is present.
Sir, she had the scoring in the upper lips. Upper lips were there. In the arms were there. In the upper abdomen, in the thighs. So all these 4 areas having a score of maximum score of 2 she had, which leads to a total
Is it
score of 8.
is it just hypertrichosis that she doesn't have pigmentation? She doesn't have hyperpigmentation, so it's at least theoretically.
No, sir, she
or
doesn't have
clinically.
hyperpigmentation.
Yeah, clinically there is no ACTH drive.
Yes.
If you have a ACTH drive, it's different. Just glucocorticoid excess. Normally, what do? They just produce hypertrichosis, no? Is it that? Even I'm not able to see much here, except in the side locks here a little bit. I can make out, but otherwise I'm not able to see much. How do you define terminal hair? How is it different from hypertrichosis?
So the terminal hairs are typically triangular and coarse in consistency.
What's the diameter, thickness?
Thickness, I'm not sure of, sir.
Yeah. Anish? Aruna?
Exact thickness, sir, I'm not aware of.
Okay. Because it's hardly visible. I mean, this is what I can deduce from the films. So it's more like a...
It is 6 by 30. I think is less than that. But anyway, there is evidence of little increase in the facial hairs, some terminal and more villous hairs. Yes.
Yes, sir.
But you should describe the distribution of hairs, that is splitting of hairs.
Okay, sir.
But you should describe it. Even though it is splitting of hairs, you must describe it, right?
Okay, sir.
Okay. Yeah.
Sir, regarding the important findings in the systemic examinations in the neurological system, we have specifically inquired about the lower limb proximal muscle spar, which came as 4- out of 5. Other than that, in CNS, we didn't have any evidence of any visual field defect or any cranial nerve palsy. And apart from the increased blood pressure, systolic and increased blood pressure, the rest respiratory system, cardiovascular system, and the GI system didn't have any other abnormalities. So with this history and examinations, we had a provisional diagnosis of likely an ACTH independent endogenous hypercortisolism or Cushing syndrome. After this history and examination, is the provisional diagnosis. So we'll move forward with the investigations. So I have categorized all the investigations into the various parts.
Okay. Out of these, you said that ACTH independent Cushing. Can you also guess the possibilities of the etiologies of ACTH independent Cushing in this age group? Based on which one is the common occurrence, then the uncommon occurrence, and the rare occurrence. Based on these 3, can you put a list of the etiological causes of ACTH independent Cushing's?
Sir, at this age group of around 15 years, 16 years, the commonest cause among the ACTH independent is the commonest is adrenal adenoma, followed by PPNAD, followed by AIMH. The rare possibility will be an adrenocortical carcinoma.
Okay. Right. So, yeah, you should mention that also. No harm in telling those etiologies here. Once you have made it provisional, I think better to. That will help us in learning and in getting good experience from each and every case, right? Okay.
So going into the investigations, first I have tabulated the screening test of the Cushing syndrome. So all were suggestive of a very high cortisol load and a florid Cushing's syndrome. Like the midnight serum cortisol came at 28.2 microgram per DL. It was an awake specimen. The basal serum cortisol next day we have sent morning, it was 34.54 microgram per DL. Then the 24-hour urinary cortisol, it was 868, more than almost 4 times of the upper limit of the lab range. And then we did the overnight dexamethasone suppressant test after 2 tablets of 0.5 milligram or full dose of 1 gram. So that came as 28.03. So the screening test confirmed as a case of a Cushing's with a very high cortisol load. Then, sir, about the other metabolic.
Go back to the basal cortisol 34, and then you did another test. Do you really require another test?
Sir, among the screening tests, positive screening tests
like in this case, did you require two more tests, like 24-hour urinary cortisol and ONDST?
Sir,
with the clinical features which I have already learned and the diagnosis provisional made with the basal serum cortisol 34, do you need to go for 24-hour urinary cortisol ONDST together?
Sir, 24-hour urinary cortisol will give us a good idea about the cortisol load.
Okay, coming to 24-hour urinary cortisol, what are the caveats of doing 24-hour urinary cortisol?
Sir, I missed it. What are the
caveats or the pitfalls of measuring 24-hour urinary cortisol?
Sir, first of all, in a 15-year-old or in a younger population, the first problem is obviously the urine collections.
The collection second. The collection problem collection.
Second is any associated drug effects which can affect the urinary cortisol levels. So patient was not on any drugs, but some drugs can affect the urinary cortisol values as well.
Okay. Third.
Then, sir, pre-analytical error can also be a very important cause in a urinary cortisol. Storage and sampling and transportation to the lab, that can also false.
Okay. So there are so many limitations anyway. So in this case, you had done 24-hour also ONDST. Okay?
Yes, sir.
Which one is better, ONDST, or should we go for low-dose dexamethasone as a screening test?
Sir, in this group of population, ONDST is not much studied. So the cutoffs and
so between the two, the
LDDST is better, sir.
It has better specificity. So, okay, right, go ahead.
Okay.
So we know what we are doing altogether, right? Okay, next.
Sir, about the other metabolic parameters, the complete hemogram reveals the hemoglobin of 6.1 of the total count of 11,690. That's 70% of neutrophils. It was creatinine of a 0.75.
This is normal. Everything is normal.
Is normal. So this was just a print.
So what's very important in the total count, differential count?
So differentials counts in the Cushingite cases, we can get a leukocytopenia and more of a neutrophilic percentage.
What's very important? What is the thing you'll have to look into this in this DC?
Sir, higher neutrophil count and lower lymphocyte count.
Anything else?
What is more glaring in this? You should have focused that first. What is glaring abnormality? Yeah.
There is zero eosinophils.
The first one.
Yes.
The first one on the top.
Hemoglobin, sir. Hemoglobin 16.1.
What does that indicate?
Yeah.
Androgen exposure, sir.
What does that indicate?
Androgen
exposure. Right.
Yes.
So there is a clue that the child is also having excess of androgen production. And there was some clinical clue also, and there is another biochemical clue. Okay.
Right.
And then you have the counts, as we have already discussed. The count is also on the higher side. Okay.
The sodium potassium is 23 by 0.5.
Yes, sir. Sorry, that's a small.
No, that's this should be.
The sodium. Yes, sir. So this is just an.
This is KFT basically.
This is the KFC.
Blood urea and creatine ratio.
Yes.
Okay. Right.
So and also here we should focus on the eosinopenia also. Zero is there. So that's another thing.
Yeah, eosinopenia is there. Yeah.
So the rest parameters, the electrolyte, sorry, sir, I just misstated. The sodium was 136 and the potassium was 4.4. The in liver function test, it was within normal limits with a total bilirubin of 0.26. The glucose tolerance test we have taken at the fasting and 2 hours, that was 86 and
Yeah, I
90.
think that's fine. Go ahead, because
Okay.
we have
The
limited
related
time.
hormonal workup we had done. In the thyroid profile, we got a TSH of 1.8 and FT4 of 1.34, a prolactin of 5.33 nanograms per ml, FSH LH of 3.57 and 0.44, and IGF-1 was...
Why so many hormonal profiles were done?
So thyroid profile was done, and IGF-1 was
Why
done.
thyroid profile in this case when you are suspecting adrenal cause? That we have already discussed, the provisional diagnosis.
So any associated hypothyroidism was there, which is more... any primary hypothyroidism was there, which is more relating to the short match, which is...
But don't you think that we should not think of too many diseases at a time? We should manage one with, right?
Yes, sir. Yes, sir.
I used to tell to my patients also, don't go for so many. When tire is punctured, why open the engine? So you go simple. And the why LHFSS was done?
Yeah, otherwise what happens, one set of investigation will lead to another set up, and then it's never ending.
Yeah. Why LHFSS was done in this case?
Sir, we mostly did as a routine hormonal workup.
No, this is not routine. The child is 11 years, B3, you said the P3.
Sir, also, if as we are also, we had the minimal suspicions of a pituitary disease, so that's why we have also done the IGF-1.
No,
Sir,
I
now
don't think.
she is now 15 years, 7 months, sir. Right now.
Okay, sorry, 15
years,
so,
7 months.
Yeah, we expected that there is a P3 also. I think I heard
P3 and B3.
B3.
Yes,
so
sir.
that tells about the LHFSH. Right? And why IGF-1 then? Why IGF? Yeah.
Sir, to just the rule out about any growth hormone secretions, even outside the pituitary causes. If we just have a, in the pituitary causes, or if he's syndromic causes like Carney's.
Yeah, but we don't expect anyway. And it is an expensive test, and we know once you diagnose Cushing, is not simple. Is not simple for anyone. So IGF-1, I don't think that there is any place for such investigation when they do not have relevance in the management overall of the case. So focus on the case. Go next to next test.
Sir, about the bone mineral workup, we had done about the calcium, phosphorus, and 25D. The calcium was 10.12 and a phosphorus of 4.16 with a 25D of a 32.8 nanograms per DL, and the PTH was 64.5 picogram per ml. Also,
so how do you interpret this? The calcium is 10.1 with the IPTS 64. 20-hydroxy-32.
Sir, this IPTH is just towards the higher range, and this 25D falls.
How do you explain this?
So 25D hydroxy falls in the sufficient range, but just falls in towards the lower range of the normal sufficiency range. So maybe
yet it is showing more effect. It's showing more effect with a calcium of 10.12.
Yes.
You see, when you do so many tests, this is what Dr. Ganpati was also referring. If you go on doing many tests, it becomes a big challenge to explain why. So PTH, what was the indication of doing PTH in this case? Okay, urinary calcium is all right because patient had a stone.
Yes,
so
sir, that's why.
How do you read this 2.64 per milligram per kg?
Sir, the urinary calcium was however 2.64 milligram per kg per day. But
normal or subnormal?
Sir,
normal
it is
or
in
subnormal?
It is
in
normal range, yes.
Okay. So don't have any clue. Rather, we have more of the complications arising out of this test. Anyway, next.
So then we go for the etiological
workup. When you have done PTH also, the calcium, urinary calcium, so many things. Any important relevant test in relation with the assessment of bone mineral that has not been done?
So
if at all you have gone.
Sir,
Alkaline phosphatase. Okay, yes, alkaline phosphatase may not be.
sir, about the
Anything else?
sir, about the bone health, with the DEXA scan.
DEXA scan.
Sir,
So how
DEXA
do you see osteo?
Sir,
it has
I
been
have done. I will show it later, sir. Just
okay. We'll come to that. Also.
Yes.
But we have shortage of time. Seems we don't have too much time.
Yes.
Okay, go ahead.
Next, try and wind up. Yes. Can we try and wind up?
Yeah, we should.
Yes.
Actually, we have already. Yeah.
Sir, about the etiology, we send ACTH, which came as less than 5 picograms per ml. We ensured. Okay, and the CCT showed the nodular thickening of the bilateral adrenal glands, which I have shared in my
What about the
slide.
size? Thickening and size.
Sir, size. Sir, size. They about the nodules. They haven't.
Okay, they have not
it's
mentioned.
not mentioned. So size was not mentioned.
But what you see in this diagram?
Sir, it is bilateral adrenal hyperplasia with some evidence of nodularity. This we can see in the CC.
And the more important?
And in the homogeneous texture also in the adrenals.
And the shape of adrenal maintained.
Architecture is maintained.
It is
architecture
maintained.
is yeah.
Maintained. Sir.
Enlarged, architecture maintained. Nodule we are not able to see this. But anyway, some nodularity was seen and they have been reported also. It's okay. Right. Yeah, go ahead.
So with the complications workup, we have done about the bone health and also the heart issues. The DEXA scan we have done, which came as a very definite low bone mass with a Z-score in the spine of -6.4 and
What do you
minus.
call this? What do you call this then?
So this is severe low bone mass.
Due to what?
Due to the chronic glucocorticoid exposure.
GIO. Glucocorticoid induced osteoporosis. Okay.
And also we had done the echocardiography, which didn't show any abnormality. Venous Doppler of the both legs to show any thrombosis, which didn't reveal any venous thrombosis. And we had also done the ophthalmology, which shows an increased intraocular pressure. So this is the X-ray of the vertebrae, which are showing compressions in almost all the vertebrae. It was a standing X-ray in both of these, and also to rule out any avascular necrosis, we have done the hip X-ray also, which didn't show any evidence of any avascular necrosis. So if we summarize it, it's mostly a case of Cushing syndrome presented with obesity and a growth failure in a pubertal stage of onset. However, it has a gradual sluggish progression of the Cushingoid features, mostly progressed over 4 to 5 years with hirsutism, marked low bone mass, cause ACTH independent and associated with a bilateral adrenal hyperplasia with nodularity in the imaging. So we provisionally diagnose at the end of investigation a case of ACTH independent Cushing's, likely a sporadic case of a primary pigmented nodular adrenal disease, with the complications of low bone mass with multiple compression fractures, recurrent renal calculi, and increased intraocular pressure. So now the patient, sir, in our follow-up is awaiting bilateral adrenalectomy, will be followed by a physiological glucocorticoids for mineralocorticoid supplementation. We will confirm in histology followed up in that. And also we have planned to send the genetic testing for PRKR1A mutation for after the histological confirmation of PPNAD defects.
Only one genetic testing? PRKR1A only?
So that is the most common cause of mutation in the PPNAD.
How that helps in
sir, if
this case?
Sir, yes, if we get a case of PPNAD, also this managing.
What is mode of inheritance? What is mode of inheritance?
Autosomal dominant.
Dominant is the.
Yeah. Right. Dr. Ganpati, you have because we have very limited time left. Yes. So, fine, looks like a case of PPNAD, sporadic variety. We can't say familial, which is common, but sporadic. And bilateral adenylectomy. Do you know that they can do unilateral adenylectomy also in PPNAD? Is there any? Have you read any article?
Sir, about the
unilateral adenylectomy.
The remission rates are not very promising compared to the bilateral anemia.
In mild cases with PPNAD, unilateral adenylectomy has also been helpful, but not in this case. This is not a mild. The presentation had been quite obvious for last 4 or 5 years. Growth failure, the other metabolic complications. Bilateral adenylectomy.
Usually PPNADs have a robust cortisol secretion.
Yes, sir.
Yeah, Dr. Ganpati, you are. So should we wrap it off? Dr. Somik, do we have time or?
No, sir, we are out of time. We are out of time.
Oh, okay. So I think the case was very well presented, but the only message is that you focus to the presentation and the frequent management. Don't go around and look for so many things which are not in our hand to control at a time. So better to focus on the case first. As in this case, somebody focused only on the growth failure and then managed. Somebody focused only on the bone problem, or somebody focused on the renal stones, and that should not be the right approach, clinical approach to any case. So that has been missed largely at many levels in the past. So the lesson we learned that the case is a very typical garden variety of Cushing's syndrome with adrenal cause of Cushing, and though it is uncommon to have bilateral, but still we get cases of bilateral adrenal hyperplasia. So this is a nice case. Okay, over to Dr. Ganpati for his final comments.
No, sir, I just concur with you. Already we are running short of time. Thank you so much, sir. It was being with you. Always happy to be a part with you.
Thank you, Ganpati.
Thank you. We express our gratitude.
Always.
Good morning, Subhankar. Good morning.
Good morning. Always happy and to learn from you both, Professor Singh, Professor Bansal. Thank you very much for joining.
Thank you, sir.
Excellent program. Excellent program.
Yes. Thank you. Thanks to both our examiners. We move right away to our second competitive session for this year's Endocrine Enrichment program. We had the Hawkeye yesterday. The results will be announced at 1:30 p.m. this afternoon. The session that we are about to begin now looks at the ability of our participants to critically analyze published articles in journals, the so-called endocrine wise out. And as judges for this session, we have a very illustrious and eminent panel of endocrinologists. We have Professor Nilanjan Sengupta, we have Professor Tushar Bandgar, we have Professor Sushil Gupta, we have Professor Riaz Ahmed Biskar, and we have Professor Mohammad Ashraf Bani, who will possibly join us a short while later. Initially, we had received around 29 entries. 5 finalists were selected. I'll announce their names, and in the sequence that I'll announce their names, that will be the sequence of presentation that they will that will take place. So first, we'll have a presentation from Dr. Krishna Prabha, followed by a presentation by Dr. Orijit Chenko, followed by Dr. Afsar Fatima, then Dr. Johan Varghese, and finally Dr. Abid Rasul. I invite Dr. Krishna Prabha to begin her presentation. The rules are simple. There are 4 minutes for presentation, followed by 8 minutes of questioning by our panel of judges. So we begin this year's Endocrine Wise Owl with the first presentation by Dr. Krishna Prabha. Over to our panel of judges to conduct the rest of the session.
And Dr.
And
Shobhit,
I'll be keeping the time, sir.
Yeah, okay.
Good morning. Am I audible, sir?
Yes.
Are my slides visible, sir?
Yes, go ahead.
Good morning, respected teachers and dear friends.
Slide presentation mode?
Yes, sir.
Thanks.
So I would like to first of all thank the Endocrine Enrichment Program and the Endocrine Society of Bengal for giving me an opportunity to present in this August forum. The article which has been allotted to me is a critical appraisal of the article Investigation of Mechanical, Material and Compositional Determinants of Human Trabecular Bone Quality in Type 2 Diabetes mellitus. Now this was an article which has been published in the JCEM, and it is an Indian study from PGI Chandigarh with biomechanical engineering help from IIT Ropar. So we all know that osteoporosis is a systemic skeletal disease which is characterized not only by low bone mass but also deterioration in the bone microarchitecture, which leads to an increase in fragility fractures. And there have been number of studies which have been coming up showing that individuals with type 2 diabetes mellitus, they have an increased risk of fragility fractures compared to non-diabetic subjects despite a normal or increased in the BMD as assessed by a DEXA. So this has been attributed to the poor bone quality, and this is not routinely evaluated in our clinical practice. The closest we get to is a trabecular bone score, which is a non-invasive practice but not very accurate. So we need further insight on the pathogenesis of type 2 diabetes mellitus related bone fragility as exemplified, like what are the parameters in bone quality which is affected. So the objective of this study was to investigate the role in altering the biomechanical, microstructural and compositional properties of the bone. So this study has addressed a very valid and a clinically relevant objective, which can be translated into clinical practice. So the methods which were used were, they took the bone samples from two groups of patients who underwent a bipolar hemiarthroplasty or a total hip replacement following a first fragility fracture of the hip. They divided patients into without diabetes of 40 patients, with diabetes of 30 patients. So it is like an observational or a case control study. And type 2 diabetes mellitus was diagnosed according to the American Diabetes Association criteria. The patients who were included were those with a first fragility hip fracture. They took all the demographic as well as the treatment history, and anti-diabetic medications, metformin, sulfonylurea and insulin were included, but none of them were on pioglitazone or SGLT2 inhibitors. And they excluded those patients with cancer, osteoarthritis, renal dysfunction, primary or secondary hyperparathyroidism, unexplained elevated alkaline phosphatase, or other causes of secondary osteoporosis like a chronic steroid or an anti-epileptic use. So what they did was, the femoral heads of these patients who underwent this arthroplasty were obtained, and they took this trabecular bone cores. They were cylindrical bone cores which they obtained with a diamond core drilling machine, and the bone cores had 5 mm diameter and 8 mm length. And after that, these bone cores were subjected to different studies for analyzing their architecture, like a micro CT. They were subjected to different loads like a nano indentation to know the biomechanical property. They were subjected to this fluorescence advanced glycosylation and
30 seconds remaining for
so all these bone quality parameters were assessed, and in the results we find that the most of them were females in the age group of 69 to 70 years, and the most significant was the HbA1c, elevated HbA1c. The T scores were comparable between the two groups, and we can see in the analysis that all the structural parameters were significantly reduced in the diabetic patients, like the structure.
4 minutes are up. 4 minutes are up.
and the non-enzymatic glycosylation end products were all increased in the diabetic patients. So load bearing and energy absorption capacity was significantly compromised, and they had a higher FAGE concentration, and these elevated HbA1c, phage and non-enzymatic cross-linking correlated negatively with the biomechanical properties. And if we see the ANCOVA analysis of these are all analysis which they have done, and the strength of the study was that it is an investigation for the first of its kind which links the bone biopsy with the diabetes mellitus and fragility fractures, and they have objectively documented the detrimental effects of hyperglycemia on the bone quality. But the limitation of this study is that they have not included the non-fracture controls with and without diabetes. Probably it's an ethical issue, and we cannot obtain bone biopsy from patients who don't have a fracture. And this has focused mainly on the hip, which is mainly a cortical bone, and it is analyzed the trabecular bone properties, and it is a small sample size, and they have not mentioned other comorbidities like risk of falls, etc. So even given these limitations, we have to acknowledge that it is a well-conducted study, and in clinical practice now we know that hyperglycemia does lead to increased enzymatic cross-linking products, and this is going to increase the risk of fracture in our patients. Thank you.
Okay, well presented study. So what is the implication in a clinical practice? A type 2 diabetes patient comes with a normal BMD, and then do you have to change any cutoffs or something to really tackle this bone quality? What do you think about it?
Yes, sir. So in type 1 diabetes, it is always a lower BMD that we expect and we have seen. But in type 2 diabetes, we see that patients who have, they usually have a normal or increased BMD, though they have an increased fragility factor. So what we can do is we can do a FRAX adjustment of these scores. Like these are all proposed mechanisms. Like we can add a 10 years more age to the FRAX when we calculate the FRAX score. Usually this BMD in type 2 diabetes, it underestimates the fracture risk. So what we can do is we can add another 10 years to the age, or we can subtract minus 0.5 from the femoral neck BMD score also. So all these are being proposed.
Okay. And so what about those drugs, anti-diabetic drugs, which add to the deterioration of bone mineral density? About SGLT2 inhibitors and PIOs, what is the mechanism of pioglitazone?
So pioglitazone is actually a PPR gamma agonist. So what it does is that it can increase the adipogenesis. Like when there is a mesenchymal progenitor which differentiate into the adipogenic and the hematopoietic cell line, because this is a PPR gamma agonist, it can actually increase the adipogenesis within the bone marrow, and this can lead to increased fatty tissue and increased propensity to fracture, rather than the bone differentiating into the osteoblast and clast.
Okay, so as such, pioglitazone is to be used as a third or fourth line agent. You will never use patients pioglitazone in type 2 diabetes management?
We do use them, but not in elderly females who are elderly ladies who more than 60 years. We don't prefer, because they have an increased risk of osteoporosis. We don't use. And also fluid retention and other adverse effects are there. So more than 60 years we don't use.
What about SGLT2 inhibitors?
So SGLT2 inhibitors, it has not shown a definite risk of fractures, or there was reports of in the canagliflozin causing increased risk of lower limb amputations and surgeries, but it has it is still to be studied. So whether it does cause an increase in fractures, so there is no definite data of regarding fractures.
Okay.
Couple of things. Can I ask? Dr. Niranjan, please go ahead.
No, okay, you go ahead. I'll ask later.
Good presentation. It has got some clinical correlations actually, but this study has been done in the tissue sample from the hip actually. If you want to translate the study to clinical scenario, what is the investigation of choice you would like to do?
So, first of all, this study you are asking, so, or a trabecular bone score is what we use as a non-invasive measurement of bone microarchitecture, or
trabecular bone score is a derived one actually.
It's a derived, yes, sir. So bone
it's based on a software where you have a voxel size and you are looking at a density of various parameters, and it's a derivative. Do you have any other direct measurement which you can think of? You are doing the structural parameters in vitro. Basically, you have taken the hip samples.
Yes, sir.
Do you think of any other investigation which is available in today's date at some of the centers across the world where you can do further studies?
So the transiliac wrist bone biopsy?
That is going to tell you, yeah, you are right.
The peripheral
this is another biopsy actually.
Yes, and other parameters like a quantitative CT, quantitative MRI, they are available.
Quantitative CT again measures the bone density. It's as good as DAXA. I'm not talking sensitivities per se. Quantitative MRI, I don't think it is. Which one? Quantitative MRI. There is one, yes. Which one?
I'm not sure of that. And
number two, what is the advantage of doing you took the bones from the hip,
sir?
From the hip, right?
Yes, yes, sir.
And from the head of the hip, actually, right?
Yes, sir.
Any difference in the mechanics of hip bones vis-a-vis vertebral bone? We know that vertebrae are more likely to fracture at the early age, and if fractures happen later in the age.
Yes.
So any difference is likely to be there if you drive this thing into the clinical practice. Doing the study of the vertebrae vis-a-vis in the hip are going to be different.
Yes, yes. The vertebra has the vertebral fractures are more relevant because they contain a more amount of trabecular bone compared to the femoral bone. So hip is
what percentage of trabecular bone is a vertebra vis-a-vis versus percentage of trabecular bone in the head of the femur?
So almost 80% of vertebra will be cancellous or trabecular bone compared to the femoral head where it will be only 20 to 30%.
So, and you know the pathophysiology, that the pathophysiology is more on the trabecular bone than the cortical bone. Is that right?
Yes, yes, yes.
Number two, is there any role of bone markers in this kind of scenario?
So,
which bone markers would you like to do in a case with osteoporosis, with or without fracture, and why?
So the bone turnover markers we usually do are the P1NP, that is the procollagen N peptide, and the beta cross slabs, and procollagen N terminal peptide, and the other marker now coming is the pentosidine, which is actually going to which has a correlation with the non-enzymatic glycosylation end product. So pentosidine will be much more helpful in becoming further.
Over to Dr. Nilanjan, please.
Yeah, a short question. Did they look at the calcium, vitamin D status of these patients? Because do you think that is important and has any bearing on the outcome of the study, observation?
Yes, definitely, because we know about the high incidence of vitamin D deficiency in our population, and vitamin D causing osteomalacia is a very common problem. So we have to ensure that so in this study they have ensured that both the cases and control groups have a normal calcium phosphate and 25 hydroxy vitamin D.
We have a minute more for this presentation.
Hello? Hello?
Hello?
Hello?
You're audible. You're audible.
Yeah. Can I also ask some question?
Yes, sir.
Prabha, very well presented, but I would like to say this is a disease where you have multiple factors, including pharmaceutical agents, complication of diabetes. All those factors can actually affect bone health. So I would like to know how they use it by a statistical analysis to remove the confounders. Have you gone into the statistical component of this?
Yes, sir. So they have used, to compare the two groups, they have used student t-test, and then they have used a Pearson correlation coefficient, and then they have used the ANCOVA analysis. That is ANCOVA analysis, that is they have used one covariate correlating with the other variables. So these are the statistical studies which how they analyzed. And they have.
Suppose you have to take a study like this tomorrow, and you would like to remove all confounding variables, all confounders, whether it's anti-diabetic drug, a complication of diabetes, or any other issue which has happened. It doesn't happen in 2 days like vitamin D and calcium will determine it. It is over the years what has happened to the bone health. So how would you remove those confounders in your study? If they have not done any test, what would you do?
So they would be matched, matching and homogeneity would be done by, I'm not sure of the tests.
Okay. Okay.
Thank you. Thank you, Doctor. Last question.
Last question. Which is, some of these patients were on insulin.
Yes, yes.
What is the effect of insulin on bone density and or bone quality?
So insulin is an anabolic hormone, so it can increase the bone density.
It has any effect on the bone quality also?
Yes, the other in the anti-diabetic usages of insulin, it can increase. It is said to be beneficial to the bone quality also.
Okay, let us conclude this.
Thank you. Thank you, Dr. Krishna Prabha. We right away move over to our next contestant, Dr. Arijit Shingho. You have 4 minutes for the presentation, followed by 8 minutes of questioning by our panel of judges. I'll be keeping the time as
First,
usual.
Dr. Krishna Prabha is to unshare. Stop sharing. Krishna, please stop sharing.
Dr. Krishna, please stop sharing. Okay, thank you. Dr. Arijit, please.
My slides are visible, sir, and I'm audible.
Yes.
Yes, you.
Good morning, my respected teachers and faculties. In the next few minutes, we will critically try to critical appraisal of this article, which has been published recently in NEGM by Teresa A. Hillard, a pragmatic randomized clinical trial of gestational diabetes screening. So why this trial? So gestational diabetes mellitus is one of the most common complications of pregnancy and associated with adverse fetal and maternal outcome. Around 60 to 25% of the mother are affected by the GDM. Universal screening recommended at 24 to 28 weeks of gestation by 2 methods. By one-step glucose tolerance test, which is endorsed by the American Diabetes Association and IAD-PSG group. It is based on the HAPO study done in 2008, and it detects the mild hyperglycemia as GDM as well. The second one is a 2-step method, which is endorsed by the ACOG and is predict the development of diabetes mellitus after birth. Surprisingly, there is no consensus on these screening methods, and in this trial, there is head-to-head comparison between these two screening tests. So we all know about the one-step 75-gram oral glucose tolerance test. Regarding the 2-stage oral glucose tolerance test, which is also known as Carpenter 2-stage criteria. Initially, the patient need not to have first. Patient is giving 50 gram of glucose, and if the blood sugar is more than 200, then it is clear-cut diagnosis of GDM. If it is more than 130 or 140 to less than 200 milligram of DL, then the patient is subjected to second time test by giving 100 milligram of glucose. And the blood sugar is taken fasting 1 hour, 2 hour, and 3 hour. And these are the cutoff we often used. So this trial has been done in 2 clinics of the United States. This is a Kaiser Permanente New West Clinic and Kaiser Permanente Hawaii Clinic. This is separated by around 2,000 miles, and it actually caters to different group of population. We have to keep in mind that though this is a randomized control trial, it is not been probably blinded, number 1. And number 2, the individual consent for the patients has been waived. Initially, at the time of antenatal clinical visits, the patients were assigned to 2 groups by generation of random number. One group is 75 gram oral glucose tolerance test, and the second group by 2-step. The patients are followed up to 24 and 28 weeks. At that time, the patients were subject to test for which they have assigned, and they are followed for maternal and perinatal outcomes. So this is the consort diagram. You can see that around 36,000 patients were screened without any history of type 1 and type 2 diabetes mellitus. 11,000 patients were excluded. The important point to note here that the multiple gestation patients were excluded. After that, 24,000 were eligible for screening. They are divided into 1:1 group, and you can see that patients who are assigned to 1-step glucose tolerance test, they found that they are not adhered to their group. For that reason, the provider or the investigator extended the trial to accumulate more amount of patients for statistical significance and to do intention to treat analysis. So what are the parameters? There are primary outcome parameters. It is diagnosis of GDM based on screening approach, macrosomia as defined by birth weight more than 4 kg, composite perinatal outcome of stillbirth, neonatal death, etc.
30 more seconds. You have 30 more seconds.
Preeclampsia, secondary outcomes, large for gestational age as evidenced by birth weight more than 90th percentile, small for gestational age, maternal GDM, neonatal respiratory distress, and individual components of composite perinatal outcome. So these are the baseline study parameters. We can see the parameters are more or balanced between these 2 groups. The mean maternal age around 30 years, BMI was 27.4, which is they are overweight. And regarding the race or ethnicity, the American Indians were poorly represented.
4 minutes are over. 4 minutes are over.
And 70% of the patients are actually multiparous. So what is the result? The incidence of GDM diagnosis is 2 times high in 1-step testing than the 2-step testing. The neonatal hypoglycemia was more common in 1-step group. The percentage of the women who received insulin or hypoglycemic therapy were similar in 1-step and 2-step group, and there was no difference in other outcome parameters. Interestingly, in 39% of the patients assigned to 1-step method, the diagnosis of GDM was based on an isolated fasting glucose level in the range of 90 to 94 milligram per dl. And we know that the glucose level that is within target range is less than 95. So what are the limitations? If providers were not blinded, as I have said earlier, the lower adherence to 1-step approach might have biased the findings to intensive analysis. The glucose threshold in 2 clinics are not uniform. Majority of the patients are multiparous. We know that the multiparous patients have more complication for cesarean section or any fetal or maternal outcome. Multiple gestation, which is more important, they are excluded from the study. And the more poor representation of various ethnicities, no data on family history of diabetes or PCOS, lack of detailed glucose monitoring, prevalence of GDM or type 2 diabetes mellitus in the local population were not known. And the patient diagnosed with 1-step, will they be beneficial in the long run? This trial does not give any results. So what are the strengths? There's a good number of participants and always the pragmatic study design, that is there is a smell of real world scenario. So what we learned this from this trial, we have learned 2 lines, that is 1-step approach, higher prevalence of GDM patients, and there is no difference in maternal and fetal outcome, and further study is required. Thank you for your kind patience.
So what is your take from the study? What is the difference between 1-step and 2-step approach, and what do you, if you are supposed to make a protocol, would you shift to 1-step or go to 2-step? What do you think about after reading this study?
Sir, after reading the study, by 1-step and 2-step, doing the 1-step method, the chance of getting a high number of GDM patients is there. And if we have a high number of GDM patients, these patients will be followed up by regular monitoring, regular ultrasonography, blood glucose monitoring, and that will cost extra cost to the patients and also the caregiver. As there is no difference in outcomes with one step and two step, we can do the two-step methods also.
Orijit, if I may have a counter argument on that, if you are diagnosing more, it's becoming a more sensitive method of picking up GDM. If you can follow up with lifestyle therapy and good monitoring and unnecessarily not use insulin, what's the harm? Because in pregnancy, if you go for intensive fetal-maternal monitoring, that eventually would be good for both. Means, of course, I do acknowledge the resources would be utilized, but what's the great harm if you do it? Because it has other way, the simplicity of, diagnosing rather than the two-step methods. So comparing these two, what would you suggest in your practice?
Sir, actually, you are absolutely correct, sir. By one-step method, if we do that, it will be well very much. Patient will be followed up. But there are studies that have shown that in one-step method, if you use the one-step method, there is increased chance of primary cesarean section. That is one important harm. Whether we call it a harm or it is good, I don't know, sir. But yes, if we use one-step method, then it is yes.
Yeah, but the chances of increased cesarean section, is this an inherent fault of it's picking up more or inherent fault of the prevailing system in the country where it's being done? Means yes. Like in India vis-a-vis the United Kingdom or Australia, where even the rates of cesarean section are less, even in gestational diabetes. So yes. I think that can be up to debate.
Yes, sir.
Yeah, Arijit.
Yes, sir.
Yeah, can I come in there?
Yes, sir.
Yeah. Have they done HbA1c in this? Have they analyzed A1c data as well?
No, sir. Actually, they have excluded the patient of known type 1 and type 2 diabetes at the time of screening. So the HbA1c data was not analyzed in the baseline characteristics.
Okay. So, see, it is just an observational sort of a thing. How do they say that it is a trial? How do they qualify it as a trial?
Sir, actually, they have randomized.
To me, it is not a trial.
So actually, they have randomized the groups, the patients into two groups, and obviously the providers know that which patients will be in the which group, and they have to, clearly say that it was not blinded properly. They are also mentioned about their limitation also.
Can I comment?
Yes, sir.
Do you know about receiver operating curve? ROC curves?
Yes, sir.
What it is used for? Basically, one-step method, two-step method diagnosing diabetes in basically this. So what is ROC curve of these two methods actually? Have they mentioned them in the study?
Sir, they have not measured.
Sorry?
No, sir, they have not measured.
You understand what ROC curves means?
So ROC curve is to give the cutoff by which the sensitivity and specificity to detect any problem.
Okay. And you have got a cutoff. So they have not analyzed. Do you think would it help them to, because they are trying to diagnose diabetes and they are looking at the outcome? What is the method? Yes. So do you think the ROC curve would have helped you in diagnosing the number of diabetic cases and what is the cutoff they are going to look at?
So for ROC curve analysis, you have to do the continuous data. But the problem is there is no clear-cut cutoff by which we can say this patient will have increased risk of diabetes. In a particular
you are taking the diagnostic criteria for HAPOS trial, is that right?
Yes, sir.
So you have well-defined criteria on which you diagnosed. Right. Does it make a difference? Does it make a difference if you've done an ROC curve, criteria would have come different? Because you're looking at outcome, and HAPO trial looked at outcome actually.
Yes.
Why was they decided, but this is our diagnostic values?
Yes.
Thank you.
I'm not
Can I comment? The one-step approach, it is diagnosing more patients.
Yes.
So what is the explanation? Is it picking up more mild cases of GDM?
Yes, sir.
So what will be the advantage of treating these mild cases of GDM in the long-term effects on the child?
Sir, it has,
will have any beneficial effects on the long-term metabolic consequences for the child?
So actually, there have been reports that in patients with GDM, the child of these patients have long-term effect of metabolic syndrome. But this trial, there is no such evidence that whether these patients, there is no follow-up actually data of these patients. So they have done this limitation and said that there may be some further follow-up of those patients who are on one-step method. And definitely there is some issue right there.
So we have already evidence from studies which has shown that if we treat mild cases, it will have long-term beneficial effects on the obesity and the metabolic effects of the child.
Yes, sir.
Okay,
one more
thank you.
minute to go for questions. 1 more minute.
Arijit, one basic question. So since you are a DM candidate, you should know various classifications of GDMs. So can you tell us something about O'Sullivan's criteria? Just basic concept. What's the difference between O'Sullivan and Carpenter-Kuster? Okay, so just read that up.
Okay, sir.
Okay.
So we are just in time. Okay. So
Is there
last
any
question.
Some few seconds. What is the prevalence of GDM in Indian population? Any studies you know of?
Sir, around no, sir. Actually, I can't recall at that time.
Thank you.
Thank you, Dr. Arijit. We move to our next contestant, Dr. Afsar Fatima. 4 minutes for the presentation, 8 minutes of questioning. Over to Dr. Fatima.
Arijit, please stop sharing.
Good morning, everyone. Sir, am I clear and audible, sir?
Yes.
Yeah.
Today I am going to present an article, which is an original article, Glycemic Index, Glycemic Load and Cardiovascular Disease and Mortality. We are going to critically appraise this article, which is published in New England Journal of Medicine in April 2021. Before going to the article, the sample here has been extrapolated from the PURE, which is a global prospective cohort. PURE stands for Prospective Urban Rural Epidemiology Study. This is a large global study which was done on 667 communities in over all the 5 continents, and it includes more than 1 lakh population too. The uniqueness of this PURE study is it has taken all the lower, middle and higher income countries, and it has correlated with the cardiovascular mortality. Background of the study is there is a concern over health effects of poor quality carbohydrate foods and beverages and has increased the popularity of so-called low carbohydrate diets. Although many studies support the consumption of a diet with low GI index, low glycemic index in the prevention and treatment of diabetes, data regarding the association between low glycemic index and reduction in cardiovascular risk have been more debatable. So the research question was to estimate the association of high glycemic index and glycemic load, which is the exposure here, on cardiovascular disease and mortality, which is the outcome in the general population. This is a subgroup of PURE international cohort study. The strengths, this is a very valid and biological plausible research question. Here, in addition to the 14 modifiable risk factors, there are novel risk factors like education, literacy were also included. Limitations, similar studies have also been found like Levitan and Nagata et al. Though cumbersome because it is a large cohort study, I would like I would feel if they had extended it further and also they had included any lifestyle changes or necessary interventions and made it as a randomized control study, or they would have compared it to any other cohort without any risk factors and made it as a case control study. Study population is, as I mentioned, it is a large multi-center study. It had broad range of socioeconomic and dietary patterns. So it offers a substantial heterogeneity and diversity with a good external validity. The exclusion of those countries which had a missing data of more than 10% did not have any effect on the power of the study, which is a strength of the study. And apart from other studies, this pure study included developing, underdeveloped, and developed countries. But the authors have clarified that in spite of large group, but it was not enough to give a meaningful analysis region-wise, and the results lacked uniformity. And chunk of the population was from Southeast Asian countries, which had some skewing of data. Majority were female, and as we know, there are poor dietary patterns, quality of food, and hormonal effects on glucose metabolism and better CV outcomes when compared to other males. Degree of missingness here, which is very less, was accepted, and there were no further action taken. Methodology, baseline data was very good, like it was complete up to 98%, and the duration of follow-up was mean of 9.5 years. India had the longest duration of follow-up of about 11.9 years. There were country-specific nutrition databases with micro and macronutrients. Here the glycemic index was based on quantiles. They had divided all into 5 quantile groups, quintile 1, quintile 2, 3, 4, 5. The least being the Q1 76, highest being Q5 91, and they have used a bread scale instead of sugar scale. So they have considered a high glycemic index as above 100, not 70. They have also, while taking the type of carbohydrates, they have divided into 7 categories of carbohydrates, which is more precise. Because earlier we used to take simple and complex carbohydrates and
30 seconds remaining. 30 seconds.
Which do not reflect any physiological effect. Limitations are the data recording was not adequate. Data is skewed, so median would have been better. Daily fruit intake was not taken. Methodology, all the standardized questionnaires were adjudicated. 14 modifiable risk factors with high precision was taken. Education is also one of them. Questionnaire was more subjective. Numerical values were there, and there was a scope of recall bias. Quantity rather than quality was included. Interregional differences were there. Statistical analysis, all were well matched, all were well adjusted.
So 4 minutes are over. 4 minutes over.
Measurements and covariates are there. Results, outcomes were well correlated, including poor diet. Mortality in low-income countries was seen, which is 2.5 to 3 times higher. And the insulin sensitivity, which is a very independent marker on postprandial glucose excursion, was not taken. Death due to CV events was merely based on history rather than hospital records. These are the primary outcomes, which were significant. There was a skewing, there was a positive non-linear relationship based on the GI and the hazards ratio, both for the glycemic index and glycemic load. This is the secondary outcomes, but only those patients who had cardiovascular risk at the baseline were significant, without cardiovascular risk factors. These are the other secondary outcomes which were less significant. The outcomes of the data, the further limitations were nutrients had weaker correlations based on rural to urban, intra and inter-regional settings. Although also there are differences in calorie size, portion size, cooking pattern, eating patterns, bioavailability, mainly GI values. Cardiac events cannot be solely due to carbohydrate content of food, but also we should consider saturated fats, low fiber and protein, which have huge impact. However, the role of glycemic index as an optimal carbohydrate quality measure is still debatable. The other strengths are these data can be taken and can be extrapolated regionally. This study has emphasized on harmful effects of high carbohydrate, whereas other studies like European data, they mainly focused on the low fat diet on CV morbidity. Thank you.
Sir?
Yes, sir.
Yeah, actually, you took a lot of time. You did not comment about their analysis. So, as you know, there have been these changing paradigms from lipid story to carbohydrate story. Peer study is definitely a large sample size, but there are a lot of criticisms you can level it. You rightly said that lipids, they are also very important factors there. Second
Yes.
is physical activity. So like
Yes.
even if you take carbohydrate diet and if you are reducing the same time lipid content, this is a relative proportion. If somebody is taking higher carbohydrate, reducing lipid, and also doing less or more exercise, these variables are very important in the final outcome of cardiovascular events.
Yes, sir.
So in this study, if you are able to analyze it critically, you have to analyze critically how much was the Mediterranean area in this study, because Mediterranean diet will have a different type of fat and they will have less carb versus the suppose Asian, China, India, where we have more of carbohydrate and less of fat. Have you actually looked at that point?
Yes, sir. The most about 60% were Southeast Asian, sir. Mediterranean were hardly at 20%, sir.
So have they separately analyzed that percentage?
No,
Are
sir.
the results the same there in Mediterranean versus non-Mediterranean?
No, sir. They have not included that parameter, sir.
So that you did not take it as an important criticism. Second, lipid content. Have they analyzed the lipid content of diet?
No, sir. They have mainly taken only the glycemic index and the glycemic load only, and they are correlated to the cardiovascular outcomes, sir.
Okay.
Can I comment?
Yes, sir.
Can I comment?
Yes, sir. Yes, sir.
Officer, you have done the cut and paste from the article, isn't it? You have noted down all the statements written in the journal and did the cut and paste over there. Is that right?
Yes, sir. Part of it, sir. Yes, sir.
Majority of slides are cut and paste, which is not a good feature in a presentation.
Okay.
You should have interpreted the information and then written in words. The slides are too heavy, too complicated, and a 4-minute presentation does not carry enough message. That's one thing. Number two, when you're assessing a diet and cardiovascular risk factors, what are the risks? One is glycemic load and glycemic index, that's you're right. But what are the cardiovascular other dietary factors which you take into account? Because it is a multifactorial.
Yes, sir.
Putting a blame on one element of a diet is not complete. So what other factors could have been considered? And there are studies in multi-ethnic communities from Europe, done from Cambridge University.
Yes, sir.
So what factors you could have invoked in this study to make refinement further? Number one. Number two is, yeah, please answer this question.
Yes, sir. Lipid content, fat percentage of saturated fats, the fiber, daily fiber intake per day, because higher the fiber, lesser the cardiovascular morbidity, sir.
Anything else?
Whether it is in carbohydrates also, whether it is starchy diets or simple sugars.
Are you aware of some other epidemiological studies done from UK and Asians in UK, a multi-ethnic study? Are you aware of that study which has shed some light on the cardiovascular risk factor nations?
No, sir.
Okay. Number three is, how do you have assessed the glycemic index of these foods? What is the criteria you took? By which criteria you define the glycemic index of various foods?
So we usually calculate it as a ratio of incremental.
No, there is a standard tables actually. There are standard tables for that, from which they have derived this information of glycemic index of various Indian foods.
Based on whether it is more than or equal to 70, which is high, medium is 55 to 69, and low if it is less than 55.
Which reference they had used?
Here they have used Atkinson.
Extremely important because you have got multiple tables of glycemic index published earlier and recently by NIN. It's published in the American Journal of Clinical Nutrition in 2002, and these the gaps in the information. So that's the reason I'm asking which reference they have taken into account.
Atkinson's they have taken, sir, international tables of glycemic
Yes, AJCN 2002.
2008.
Sorry.
Yes, sir, 2008. Sir.
Okay, fair enough. Over to Dr. Bobby.
Can I come in?
Yes, please.
Sir, in this study, they have found that the association between primary outcome and the high glycemic index food was significantly higher for participants with BMI more than 25.
Yes, sir.
So how will high glycemic index and higher BMI interact to lead to the worst primary outcome?
So usually, if there is any high glycemic load, this it will trigger in insulin release, sir, which may further cause hypoglycemia after few hours. This will cause the food-seeking behavior in the person, and especially they tend to take high glycemic index foods, for again leading to obesity and insulin resistance and dyslipidemia.
So the two will add up and lead to a higher postprandial blood glucose levels.
Yes.
Okay.
Any question from Dr. Tushar or Dr. Sengupta?
I think that's okay.
No, it's okay. Yeah.
Okay, fine.
So can we move over to the next participant? Okay. So the next participant is Dr. Johan Varghese. I think Dr. Varghese is there with us. So the rules are the same, 4 minutes for the presentation.
Yes, sir. Am I audible, sir?
Yes, you are audible.
Yeah. Good morning, my dear professors. The topic is the critical appraisal of original research paper. So this was an article published in the JCEM in January 2021. It was an original research article on the plasma cell-free DNA to differentiate malignant from benign thyroid nodules, conducted in IPG Kolkata by Dr. Sujay Ghosh et al. So the approach to an indeterminate thyroid nodule has been a clinical dilemma, has been the bane for clinical endocrinologists since a very long time. Traditionally, the approach to such nodules has been a surgical removal of the nodule. Off-link gene expression classifiers or gene sequencing classifiers, such as trade names of Afirma, have been the current gold standard for evaluation of such nodules. There have been studies by certain researchers who have investigated the role of cell-free DNAs in identifying such tumors, in which they have not per se looked at the quantification of cell-free DNA, but they have tried to identify whether the mutations in the cell-free DNA or whether the integrity of the genetic material obtained from the cell-free DNA, whether it correlated with the malignancy potential. So in this study, the researchers tried to find a novel way to identify the malignant potentials in indeterminate nodules, in which they started estimating the concentration of the cell-free DNA so that it would serve as a non-invasive, economical, accurate biomarker to identify the malignant potential of Bethesda 3 and 4, that is the follicle lesions of undetermined significance and RTP of undetermined significance. So the study was a prospective observational study. They enrolled consecutive OPD patients with a clinically solitary thyroid nodule. A single radiologist performed the USG graded FNAC and they reported as per Bethesda classification. The statistical analysis that they used first they use a determination cutoff and then they use a validation cutoff. The powers of the determinations were kept at 80%, and they used the for that malignant potential to be 20:1, benign to malignant, which is similar to the ratios that are seen in the general population. Similarly, validation cutoff also, they assume that 25% of all the indeterminate nodules would be malignant, which is again similar to the various research studies which have shown that there is a chance of 25% malignancy in these indeterminate nodules which are falling in Bethesda 3 to 4. So this was a study methodology in which 119 patients were selected, and they found out 119 patients. There was a determination cutoff in which they derived the cutoff in the benign lesions and in the malignant lesions, Bethesda 2 and Bethesda 5 and 6. So they were able to find out that after using an ROC curve analysis with 0.992 of the AUC curve with very good statistical significance, they determined a cutoff of 67.9 nanogram per ml for a cutoff beyond this was suggestive of malignancy. And this cutoff they applied to the Bethesda 3 and 4, that is the indeterminate nodules, which was the validation cohort. And in this cohort, they identified that among the benign patients and among the malignant patients, this was giving a very good result, in which those patients who had a cell-free DNA concentration of more than 67.9, they were able to identify all the malignant tumors. Only one they were able to identify as benign. But when it was less than 67.9, they did not miss out any malignant tumor, which had a sensitivity of 100%, a specificity of 92.3%. They used a coefficient, Cohen's kappa, which suggests of an agreement between the two, with the histopathological diagnosis and the cell-free DNA diagnosis. And any value which was more than, they found a value of 0.94. Any value more than 0.9 is considered almost excellent diagnostic capability. So with this, they found out a positive predictive value of 96% and negative predictive value of 100%. So the strengths of the study were, it was novel, accurate, and economical, which in turn translates to patient satisfaction and physician satisfaction in the essence that they do not need to again invasively get an FNAC material. It was a well-structured design. The single radiologist conducted the guide FNAC, reducing inter-observer variation. The sample size estimates were as per the population estimates, which have already been explained. The
30 seconds remaining, 30 seconds.
Yeah, an excellent statistical agreement and confirmation of quantity and purity was done with two established modalities, and established the source of DNA to be from the thyroid by using detection of driver mutations and fall in levels post-surgery, and identified what they set out to achieve with high statistical significance compared to the current gold standard of histopathology and aphaorma. And in addition, they were able to demonstrate histopathological concerning features on the basis of cell-free DNA. The limitations were, it was a single center study. The time course was not mentioned in the methodology. And the histopathological diagnosis was not mentioned, run from a single pathologist or multiple pathologists.
4 minutes are over. 4 minutes over.
Yes, sir. Patients with non-diagnostic samples were excluded rather than called back again. Medullary thyroid cancer, MNG, were excluded. They did not compare with the existing standard of gene sequencing classifiers and gene expression classifiers. And aggressive histological features could not be differentiated by the cutoff as shown in the study. And a disproportionate percentage of indeterminate, in this study, indeterminate nodule malignancy percentage turned out to be 65%. And the limitations were not mentioned by researchers. So generalizability, it is a proof of concept study, needs to be validated in a larger and diverse population to be considered for clinical usage. And impact, it's a very interesting biomarker with immense clinical potential in determining the nature of the neoplasm and easing the management considerations, throwing light on aggressiveness, completeness of surgery, probably even therapeutics of malignancy by identifying the driver mutation. Thank you.
Thanks, John.
Hello.
Yes, sir.
Yeah. So in the paper, what was the true negative rate?
Sir, the true negative rate in the sense like they were able to put the specificity which you mean to say, sir. The specificity, sir, they were able to identify that among the values that are more than 67.9 nanogram per ml, they were able to identify all malignant tumors. Out of that, one came out to be benign, sir, which came to 93.2%, sir.
Johan,
yes,
may I ask you a very basic question? You have presented well.
Thank you, sir.
What is the basis of looking at this cell-free DNA to differentiate between a malignant lesion and a benign lesion? Means how will they behave differently in life so that you can use this as a diagnostic tool?
Yes, sir. In this particular study, sir, they were able to show that you have a higher level of cell-free DNA, a malignant tumor would be releasing a larger amount of cell-free
Why?
DNA.
That's what I'm saying. Why? What's the basis? What's the pathobiological basis of this dichotomy?
The reason could be, sir, the higher proliferative potential of these tumors, lack of integrity of these cell-free DNAs is released into the circulation because of the neoplastic potential.
Yeah, maybe. Okay, thank you.
Can I come in?
Yes, sir.
After going through this paper, how will you defend that the source of cell-free DNA was from the malignant thyroid tumor and there was no other source?
Yes, sir. I didn't mention that, sir. In the study, in this study, what they did was prior to surgery, from this tumors they got a cell-free DNA. 2 weeks post surgery, again they went for a cell-free DNA, and they were able to identify that the levels prior to surgery and the levels post surgery, there was a significant difference, sir. There was a fall in the levels. For example, if the mean before surgery was around 85 to 100, the mean post surgery was only around 18 to 20, sir. So they were able, that is one. Secondly, they were able to identify in these cell-free DNAs, they were able to identify driver mutations like RET PTC, PPR, gamma related, BRAF. They were able to identify these driver mutations in this of the repeat FNA sample of these tumors. In that manner, they were able to say that the source is coming from the tumor itself.
Another surprising finding is that 65% of the indeterminate nodules were malignant. This is too high if we see textbook or other literature.
Yes, sir.
So
Yes,
can
sir.
you give an explanation for that, why it was so high?
Yes, sir. So, sir, one thing is the study was a single center study. It was taken from a comparatively smaller sample size, sir. And secondly, in another study, sir, in another research article by Pupilli et al. In Italy, they were able to show another similar 63% of malignancy for these indeterminate nodules. But the majority of the research papers on this particular category of tumors shows the malignancy rate to be around 20 to 40%, sir, in these Bethesda 3 and 4 stages. In this particular study, they acknowledge that. The researchers acknowledge this issue, sir. And they said probably it's because of the small sample size.
Okay.
Okay, one question from my side. So they've compared standard of care is GEC, as that's what has been said. So can you just explain what is the concept of GEC and what's rule-in method and what's rule-out method?
Yes, sir. The gene expression classifiers and gene sequencing classifiers, sir. So current standard of care has been using Tyrosec or Afirma, sir. These are the registered modalities in which they do these tests, in which they are able to identify the genes, sir, particular genes which are associated with these malignancies. For example, in Afirma, sir, they use 142 genes, which is done on a microarray analysis, and they were able to identify those genes which are specific for papillary thyroid cancers or for these potential malignancies, sir. And if at all they come positive, then we can say we can rule in the malignancy and we can say that the malignancy is present. If it is absent, then we can rule it out, sir. The second one is again Tyrosec also, sir. They use next generation sequencing, and similar happens with Thyromir, sir, which is again a microRNA sequence analysis. So whenever it comes positive, they rule in the malignancy. When it comes negative, they rule out the malignancy. This particular case, they were in our particular study, they were able to show a ruling out phenomenon. That if it comes less than 67.9, we can rule it out. The benefit of ruling out, sir, is that if it comes a rule in malignancy, again there is an issue of how much extent of the surgery should be done, whether you should go for a partial lobectomy or a full therapy. But if we are able to rule out a malignancy, then it reduces the further diagnostic dilemma, sir.
So based on the results of the study, will you now incorporate in your routine practice? Because I think doing that is not a major issue. Or what do you think? Or if you want to add on something?
Sir, yes. This appears promising, but I would want a more multi-center study on this done with a larger sample size for getting a clinical applicability of these results, sir. And after that, but definitely it could act as a primer for future studies, sir. It's a very interesting concept.
Can I come in?
Yes, sir.
What is the cost effectiveness of this method actually? How much does it cost? That's one. And how does it translate into the clinical practice based on cost benefit ratio?
Yes, sir. Sir, the exact cost of the cell-free DNA, and I am not sure of, sir. But on a particular, when I went through the went through trying to search for these costs, it was found to be around 1,200 to 1,500 for one test. But I am not sure of the accuracy of my source, sir. But it has been found to be cheaper compared to the gene sequencing and gene expression classifier, sir. How much? I'm not sure, sir. And secondly, if I believe if this cell-free DNA comes into the mainstream market, they will be able to reduce the cost further, because cell-free DNA has been used in other malignancies like prostate cancer, pancreatic malignancies, breast cancers, and especially in thyroid, if it comes into play, the cost would be lower, and we could apply to more and more patients.
We have 1 more minute remaining.
Have you undergone any study of the prevalence of malignancy in a surgically operated indeterminate nodule in India?
Not gone through articles, sir.
That's one. Number 2 is when you are doing a Baptista classification and classification of these, what is the percentage of indeterminate nodules in our clinical series reported from India? Any centers study? Any centers which you can quote which has reported these figures?
Sir, around among the indeterminate nodules, sir, I would say around 20 to 30% of the nodules come as indeterminate, sir. But the center, sir, I do not have an idea, sir.
Do you know the difference between the chances of malignancy in iodine sufficient area and iodine deficient area?
Yes, sir. Malignancy in an iodine sufficient area, sir, we would get a more prevalence of a papillary thyroid cancer, and in an iodine deficient area, sir, we would get a chance of follicular malignancy, which will be more prevalent, sir.
How much difference is there? Do you know the proportions? That's the common statement. But can you go further down the prevalence of various from India?
No, sir.
Thank you.
Thank you. Thank you, sirs. We now move over to our final participant, 5th and final participant for this year's Endocrine Vaisao. I invite Dr. Abid Rasul to start his presentation. You have 4 minutes for your presentation.
Am I audible, sir?
Yes, go ahead.
Good afternoon to all of you. First, I thank to all of you that I have been given an opportunity to present this in this endocrine this platform. So I thank you for this. And the topic I was allotted was the causal association between thyroid stimulating hormone and obesity, a bidirectional Mendelian randomization study. It was published recently in JCEM and was done by some Chinese group of people. The objectives of the study were to determine and analyze the causal association between serum TSH level and obesity-related traits, that is BMI and obesity. Introduction: a number of previous studies have demonstrated a positive association between supranormal TSH and cardiovascular risk, metabolic disorders, and mortality. Moreover, even for euthyroid individuals, the elevation of TSH levels within the reference interval there might also correlate with adverse cardiovascular outcomes and various metabolic disorders, including obesity. Prospective studies have demonstrated that obese individuals generally had higher current or incident TSH. On the other hand, individuals with higher baseline TSH also generally have higher BMI or tend to develop obesity during follow-up. However, several epidemiological studies didn't reach the same conclusion. In the present study, publicly available results from genome-wide association studies, they were used to investigate whether causation exists between TSH level and obesity and to evaluate and analyze the causal effect using Mendelian randomization method. This is a new method of seeing the causal association between the two parameters. Sorry. The participants' material methods. The latest genome-wide association on TSH, BMI, and obesity were searched to obtain full statistics. TSH-related GWAS were Hunt study, which included 55,342 subjects. MGI Biobank, which included 10,085 subjects. Thyroid Omic Consortium, which included 54,288 subjects. So total SNP, that is single nucleotide polymer, were tested were 22 million. Then there was a BMI related GWAS study. There was UK Biobank and Giant Consortium, including up to 807,000 individuals and approximately 2.3 million SNPs. And obesity related GWAS database that consists of 14 relevant studies with a total of 5,530 cases and 8,318 controls with approximately 2.54 million single nucleotide polymorphisms were tested. This bidirectional two-sample Mendelian randomization was performed to explore the causal relationship between serum TSH and BMI and obesity. The inverse variance weighted method and MR-eager method were used to combine the estimation for each SNP. Based on the preliminary MR results, free thyroxine and free triiodothyronine levels were also set as outcomes to further analyze the impact of BMI on them. So why Mendelian randomization? What was the use? Actually, the traditional randomized controlled trials research, they can confirm the causal relationship between different variables, although this research is also limited by various issues. Thus, the implementation of RCTs faces many difficulties. Moreover, we cannot avoid the effect of various confounding factors or the direct influence of external intervention on the outcome in RCT research. And the sample size of RCTs are generally not comparable to thousands and millions that represent the sample size in GWAS studies. Therefore, Mendelian randomization, it is an ideal method when we need to explore the causal relationship between different indicators. For each instrument variable, that is genetic variant or SNP, they estimated the effect of externalization on outcome using Wald ratio estimation, which helps us in this. Wald ratio estimation is a method of statistical estimation which gives the.
You have 30 seconds remaining. 30 seconds.
All valid instrumentals variable estimations were combined by inverse weighted method, and the MR-eager method was utilized as a supplementation to IVW. MR-eager regression and Cochrane t-test was applied to estimate the pleiotropy and heterogeneity respectively. Both IVW and MR-eager results indicated that the genetically driven serum TSH didn't causally lead to change in BMI or obesity. Moreover, the IVW method showed that the TSH level could be significantly elevated by genetically predicted high BMI. In further MR analysis, IV method indicated that BMI.
4 minutes are up. 4 minutes up.
So, conclusion: the bidirectional two-sample MR study provided evidence of a causal association between BMI and TSH, and the further one-directional MR subsequently provides an explanation to the preliminary results. Together with TSH levels, serum free T3 levels can also be elevated by genetically increased BMI, while free T4 levels are not significantly affected by increase in BMI. Thank you, sir.
Okay. So basically, there are a lot of issues between obesity and TSH and vice versa. There have been a lot of conflicting literature.
Yes,
so
sir.
This study, what has it really added on to improve the clinical practice or understanding the pathophysiology of this particular combination?
They have taken this genetic variants into consideration, because the previous studies, what they have done, they were the virus epidemiological studies they have done, but there were very also confounding factors. They have removed this MR randomization method is one of the latest methods that has most important benefit, that it removes those confounding factors. For example, high lipids, cardiovascular risk, that it has limited those factors. That is one of the important factors that has added in this. And the previous studies, they have not found the actual causal relationship between the obesity and TSH levels. But this bidirectional, this method has shown that there is a causal relationship between genetically driven obesity and increased TSH, but not the vice versa. That is, genetically driven TSH has not led to increase in obesity.
So how does obesity lead to increase in TSH?
That is, sir.
That's a basic question, right?
Sir.
What is the mechanism? What is the known mechanism?
Obesity, actually, there is this increased
So because you get high TSH in obese
yes, sir.
individuals, right? So
Yes, sir. Yes, sir.
clinical hypothyroidism, or is it something else? What is it?
No, sir. Actually, it is not clinical. As per this study, they have found that free T3 levels are also increasing. So it is not actually due to hypothyroidism per se.
Then what is it due to? This has been mentioned in the article. Okay. So that's the concluding point, no? What is the set
sir.
point of TSH means?
So that is the yes, sir. That is the answer. This lies there because the set point in obese individual that is set at a higher level, sir.
Means what?
Means that that in normal BMI individuals, TSH can be in between 0.5 to 4.2, but in obese individuals, the same amount of TSH can be in up to 7 or 8. That means the feedback mechanism from T4 level required, that will be more, sir, in that. That means high TSH levels, set point is set at a high level, sir.
Okay. So implication is that will you treat the patient with thyroxine then?
No, sir. Actually, we have to treat the underlying cause because most of the obese patients we get, they have high TSH. So first of thing, we give them lifestyle modification, or if not possible, then other interventions to decrease the weight that subsequently lead to decrease in TSH levels, sir.
The other way around, what are the causes? So what is the mechanism of increased weight in high TSH?
Sir, that is in hypothyroidism, increased weight. One is due to increased appetite. Decrease this appetite is there, and other is there is this water retention will be there more. Glycosaminoglycans can be this accumulation of glycosaminoglycans can be there. That can also lead to slight weight gain. Not much weight gain occurs in typical hypothyroid patient. This will be 2 to 3 kgs only, sir. Not much.
Okay.
Okay. Can I come in?
Yes, sir.
Dr. Abid, I'm strong opponent of making the slides by cut and paste phenomenon actually. I'm strong opponent because the statement, this is not an ideal way of making the slides. Once you do the cut and paste, the statements are lengthy and it's not good for audiovisual presentations. That's one thing. So one should have a good art of making slides, number one. Are you aware of any Indian study of obesity and genotypes in children as well as in adults? We do have
No, sir.
2 or
Yes, sir.
3 Indian studies of genotype and obesity in Indians. Any idea?
No, sir. I'm not, sir, aware.
In the last 5 years. No.
Sorry,
This study is basically European population.
Yes, sir.
Do you think that the genotype is going to be, the GWS studies are going to be different from European population and Indian population?
Yes, sir. Yes, sir. That can affect, sir. That is one of the limitations of the study, sir, because it has been done in European population, sir. So race may be have effect on this, sir. Different.
Is there any
Genetics
racial difference in the genotype? Theoretically, you are right.
Theoretically, yes, sir.
Studies wise, do you have any knowledge about the difference in genotype in Indian population versus European population?
No, sir.
You know that we have got more basal adiposity
Yes.
in that context.
Sir, the risk of this cardiovascular diseases and
No,
BMI
that's
cutoff.
implication of vessel adiposity.
Yes, sir. That can cause cardiovascular metabolic
Do
abnormalities.
you know that why Indians have what more vessel adiposity as compared to Caucasians? Thank you, Professor.
Can I come in?
Yes, sir.
Dr. Abid, what is the mechanism for elevated TSH set point in obesity? How will obesity elevate the TSH set point?
I think that was asked earlier.
Okay.
Anyone else wants to make a comment or ask a question? If not, then Shomik, we will wind this one up.
We can move ahead. So thank you to all our participants, and of course a very big thanks to all our esteemed judges who took time out to make the very difficult decision of choosing the winner of this year's Endocrine Wise Owl. While the calculations and tabulations are going on, we'll move over to the next session. And of course, you have to wait for at least an hour and a half before the results of both the Endocrine Wise Owl and the Endocrine Hawk Eye are declared for this year's EEP 2022. We move over right to the next session, which is a lecture on the common errors that occur while we manage type 2 diabetes. And to deliver this lecture, we have none other than the very experienced and the very respected Professor Anil Bhansali from Chandigarh. So I request Professor Anil Bhansali to share his experience, his wisdom with us with regard to the common errors that occur in the management of type 2 diabetes.
Thank you. Thank you, Somik. And thank you for your kind invitation. And thank you, Shubhankar, for again inviting me for this talk. And the name goes by the errors in management of type 2 diabetes. And in fact, this is not a fault finding exercise. This is just a summary of management of type 2 diabetes. And this is mainly in a question answer format. So I think that most of the people will like it. And another important point here is that this is a very new talk which I have just thought recently. So I thought that I will share with you, and this will be useful for the clinicians and general practitioners. So I will share my slides now with you. So visible and audible also.
Yes,
visible?
sir. Yes, sir, both.
So first thing, I think what are the errors which we make in diagnosis of diabetes? The physician must be aware about the normal glucose profile, and the normal glucose profile is defined as a fasting plasma glucose of less than 100. The 2-hour PG, it is a post-glucose. It is not the 2-hour post-meal impact, less than 140. But if you do random at any time, it should be less than 140. And hemoglobin A1C should be less than 5.7. The diagnostic criteria for diabetes, the physician must be aware about the fasting plasma glucose of 126, the 2-hour PG of more than 200, or random plasma glucose with more than 200 but with symptoms. So the sensitivity of the RPG in diagnosis of type 2 diabetes is only in presence of symptoms. And hemoglobin A1C should be more than 6.5%. This has to be confirmed on subsequent day, and I will just present some cases where you can have a diagnostic dilemma and you can overcome. The criteria remains same whether the person is asymptomatic or symptomatic. The same two values you require for diagnosis, and we should use preferably more fasting than random. The reason for that is because the fasting plasma glucose is usually consistent and most reproducible, because it all depends upon your hepatic glucose output, which is fairly constant in a given lesion. The fasting sample should be taken preferably after overnight fast of 8 to 14 hours. It should not be like that. Anyone who is coming at 2 o'clock or 3 o'clock and fasting since morning is not truly a fasting, because it is altered by the all counter-regulatory hormones by that time. The postprandial glucose should be considered as a random plasma glucose for diagnosis, but for monitoring, it should be considered as postprandial glucose. The pre-diabetes, it has got two components, IFG and IGT, and we all know the diagnostic criteria for that. And both have a similar connotations for progression to type 2 diabetes. However, remember that if someone has got both impaired fasting and impaired glucose tolerance, the probability of a progression to diabetes is almost threefold higher than individuals who are having either impaired or fasting glucose or impaired glucose tolerance. The physician should also know about the venous plasma versus whole venous blood values. The venous plasma values are 10 to 15% higher than the whole venous blood, and it is mainly because the part of the volume of the sample taken is also contributed by the RBCs, and some amount of the RBCs utilizes the glucose as well. So all the values which I have presented as 126 and 200, they are all values in venous plasma. The whole venous blood values are 10 to 15% lower. The capillary glucose, now most of the epidemiological studies we do with the capillary glucose, but it is not recommended for diagnosis. However, it is useful for monitoring of disease. But now the new glucometers are calibrated with venous plasma values. So however they can be used, but still the recommendation goes by the laboratory method. The urine sugar has a no value in diagnosis nor in monitoring. A word about hemoglobin A1C and diagnosis of type 2 diabetes. ADA criteria, we all aware about that. It has a low sensitivity and high specificity at defined cutoff of 6.5%. And we all know that it is not useful in type 1 diabetes and hemoglobin diabetes. So this is our work which we did and published in JCM way back in 2010. And that showed that at 6.5%, you have got a sensitivity of only 65%. But if someone is having a 6.5%, the probability of having a diabetes is 88%. So it has got a very high specificity. So we suggested a cutoff of even a 6.1% for the Asian population to pick up more number of people, which has got a sensitivity and specificity of 81%. A word about the GTT is usually not recommended for diagnosis of diabetes. However, it has to be done with overnight fast, 150 gram carb for 3 days, no alcohol in preceding night, no exercise, morning walk or bad tea or smoking on the day of the test, and use 75 gram anhydrous glucose. Now the anhydrous glucose is available, but if it is not available and you are using monohydrous glucose, then the amount of the glucose is 82.5 gram. And only 2 samples are to be collected at 0 and 2 hours. And another important point is that don't use the glucose D and other preparations which are enriched with some orange or other flavored, because they also have a certain amount of sucrose as well. The GTT during pregnancy, if you perform, if you follow the O'Sullivan and Mahan criteria, then you take 100 gram glucose in 4 samples. However, most of the people now prefer to go for IADPSG. Here use a 75 gram glucose in 3 samples, and the values, cutoff values are 92, 180, and 153. And any single value, normal value, is considered as diagnosis of GDM during pregnancy. Many times you have a dubious values. So fasting is 115 and random is more than 200 with symptoms. So in that scenario, you repeat the random again and then you confirm the diagnosis. Fasting is 130 and the random is 180. So it means that your fasting is fitting with the criteria, but random is not. This usually happens. So again, you repeat here fasting. So the value which is abnormal should be repeated. And many times we find a discorrelation with hemoglobin A1C and fasting. So fasting is 120 and hemoglobin A1C is 6.7%. In that scenario, you repeat hemoglobin A1C. If it is more than 6.5, it is diabetes. The hyperglycemia during AMI and stress, the blood glucose of more than 140 in inpatient setting is considered as hyperglycemia, and revise the diagnosis once the stress is over. Do not use the term like mild diabetes or severe diabetes to appease the patients. It is diabetes and should be treated aggressively. A word about types of diabetes. We're all aware about the change in the classification way back in 97, but the two entities I think which are to be highlighted, one is LADA and another is Flatbush diabetes. The LADA is the age of onset is more than 30, moderate to severe symptomatic, and they are usually sarcopenic. And they don't have a lack of features of insulin. They don't have features of insulin resistance. Sugars are quite high. Ketosis may be absent at presentation. Usually, no family history of diabetes. And surprisingly, they respond to OADs initially, but they are GAD positive, and C-peptide is usually less than 0.6. So this is a subset of the patients who are to be identified. So anyone who is coming with marked weight loss and severe hyperglycemia, is 250, or if postprandial is more than 350, and in that scenario, best is use insulin, do a GAD antibody, and rule it out or rule in whether it is there or not. The another entity which is also commonly now seen in clinical practice is Flatbush diabetes. The Flatbush diabetes was way back defined in 2002. However, it is characterized by young age of onset. They are obese. They are insulin resistant. Usually because of a decay, possibly because of a severe insult to the beta cell that eventually results in DKA at presentation. And if you treat intensively with insulin, the beta cell functions recovers, later may respond to OADs. The GAD antibody is negative. So Flatbush diabetes is a diagnosis of exclusion, one. And secondly, it has to be identified as obese. Because many times we see now obese and many young diabetes that are coming with obesity, they are having even the ketones are positive. So they may be, in fact, rather than a young type 2, they may be Flatbush diabetes. The certain errors or certain points which we forget in clinical examination includes the height and weight are not taken. We are helpful in BMI calorie calculations and choice of therapy. Even in obese and non-obese, you like to use now SGLT2 and metformin together. I think that will be the one. The features of insulin resistance are usually ignored. So look for acanthosis, skin tax, double chin, and central obesity. The waistline should be measured because the connotation in Indian population or Asian Indians is that they are non-obese but central obese, and it correlates with insulin resistance. The peripheral pulses has to be examined. If there is a carotid groove, it's a surrogate marker of CAD. Absent posterior tibial or dorsalis pedis, it is more likely to be peripheral vascular disease. If there is a renal bruit, renal artestosis, which is not uncommon in type 2 diabetes, and one has to be cautious for use of ACE inhibitors, ARBs, and SGLT2 inhibitors if you find a renal bruit. The foot examination is usually ignored. Callosities, nails, pulses, and arch has to be examined. And it's one of the very important cause of mortality, particularly when the longevity in patients with diabetes is on rise. The hand has to be examined. Look for a duplicating contracture, limited joint mobility of trigger finger. And the fundus has to be examined preferably by the ophthalmologist, but now there are known medriatic cameras also, which can examine the fundus and can be interpreted by the ophthalmologist. And remember, it's one of the very important causes of paleness, loss of vision, and even the 5 to 10% of patients with type 2 diabetes, even at presentation, they may come with CSME. The next thing which comes in mind is our target. So our targets are usually confined to blood glucose and hemoglobin C, but there are many targets which you try to achieve to overcome the micro as well as macro angiopathic complications. But another thing which has been added recently is glycemic variability. Why do we have a focus on glycemic variability? Mainly because of the fact that many patients who are having even hemoglobin A1C 7 or below 7 for a pretty long time, and despite they are developing diabetic microangiopathic and macroangiopathic complications. So one of the factors which has been reported is glycemic variability. So our targets for comprehensive control of diabetes are summarized here. Fasting, postprandial, hemoglobin A1C, time in range, more than 70%. The blood pressure, LDL cholesterol, non-HDL is also to be focused. Because even if the non-HDL is high and LDL is below the targets, like below 70, still the residual risk is around 30%. Urinary albumin should be less than 30 and weight should be either ideal or reduces 5 to 10% from baseline. So these are the targets which are to be followed in clinical practice rather than focusing only on glucose and hemoglobin A1C. The next questions we have to identify rather who should be on tight control. Rather, we should always give an opportunity now for any newly diagnosed type 2 diabetes for the reversal of diabetes. For the rest of the people, those who already having a longer duration of diabetes, they should be offered on tight control. So usually not identified, but you have to be individualized. Young diabetes without comorbidities, young diabetes with comorbidities which can be taken care without producing hypoglycemia, GDM, post-transrenal transplant, and patients with acute MI and stroke, keep around 140 to 180 rather than more than 180. In a treatment strategies, so many things have happened in last 3-4 years after the emergence of the SGLT2 inhibitors and their cardiovascular renal outcome. So lifestyle modification is an integral part of the management of type 2 diabetes. Aim to 5% weight loss. And if you lose around 15 kg weight, then you may have a reversal of diabetes. One, it should be advised after evaluation for DOE, PVD, and obvious foot disease and proliferative diabetic retinopathy. A 4 kilometer in 40 minutes, 5 days a week, I think it remains a good choice. Brisk walk is the best way. Current rate for 10,000 steps a day, we don't have a robust data for it. But if someone completes 10,000 steps a day, you make around 6 kilometers walk every day. That's good. Whenever the aim is to lose weight, the walk should be a stretch rather than going for in a fractionated fashion. The reason for that, you only lose carbs, you only lose glycogen, that if you walk only for 15 to 20 minutes. But if you walk longer, then and then you require the lipolysis. And preferably both isometric and isotonic exercises should be performed. That is very important because the combination of exercises is always better than the monotonous exercises in this work. Because with aging, you also lose the muscle mass. So to overcome the sarcopenia, best is you do on isometric exercises as well. Another change which has been made in recent years, and I think the physician should be aware, from inertia to proactive approach. We usually say the patient's inertia, we usually talk about the physician's inertia to initiate insulin, but now even the inertia to initiate and increase the number of the OADs to overcome the glycemic targets. So most of the guidelines, they still talk about the sequential then combination therapy unless hemoglobin A1C is more than 9%. Only the ACE talks about the using a combination therapy even at a low hemoglobin A1C of 7%. The reason for why we have become so dare to use the combination of the two drugs to begin with the emergence of the DPP-4 inhibitors and SGLT2 inhibitors, because the risk of hypoglycemia is minimal. We have never dared to use the sulfonylurea and metformin together at a hemoglobin A1C of 7 or even 7.5%. So I think one of the reasons for that, if you continue to use the two drugs to begin with, even at a lower hemoglobin A1C, the event rate to lose the target hemoglobin A1C over a span of 6 years is less than 50%. So that was shown in a verified study where we were the part of that study from our institute and published in Lancet. And that showed that the event rate is much lesser, 50% lesser if you use a combination rather than a single drug. And another point is that even using a sequential therapy, you use one drug and within 3 months, if you are not able to achieve a target, add second. And there should be no hesitancy to add insulin if your baseline hemoglobin is 10%, or if you go by the ACE 9%, and failure with, I will say, maximum 3 OADs, and combination of these 3 OADs is summarized here. Metformin as a first-line drug, I think it will continue to remain. However, we don't have a CV02 trial like as we have with SGLT2, but it's a very time-tested, established, and free from side effects. So many mechanisms where the newer includes the potentiates the GLP-1 action. It increases the GLP-1 receptor in beta cell. There is a robust data from Wikipedia of the use of metformin. Even cardiovascular outcome is improved, but not as the trial which have been done in recent years with any anti-diabetic medications. So you are all aware about that. If you have got a cardiac or renal disease, your choice becomes SGLT2. If you have got a renal disease, the choice is again SGLT2. If it is intolerant or UTI or GMI, then you have GLP-1 agonistic analogs. So add on to metformin as second line drug, it will remain a debate. I think this is a summary of that. If you have ASCVD, you have SGLT2 and GLP-1. If you have CCF, SGLT2. If you CDA, I think a slight contention is towards pioglitazone, mainly because the two studies, Horizon and one more study, IRIS, that showed that the improvement in or better outcome in stroke after use of pioglitazone, because pioglitazone may not be the cardioprotector, but it's a vascular protector. There is CKD, use an SGLT2 inhibitors with EGFR is more than 30, and the safer DPP4 are Lina and Thanani. And if the EGFR is less than 30, you can use these two DPP4 inhibitors. The combination versus sequential therapy. So currently, combination therapy is slightly better because of sustained glycemic control, durability. Variability is reduced. Early achievement of targets and evidence by the verified trial, and you can see that the failure to overcome the targets, that is more than 7%, is almost reduced by 50% if you use metformin and vildagliptin to begin with, as opposed to metformin plus placebo. And even if you add later the metformin and vildagliptin, the outcome is still poorer than when you use a combination to begin with. The time of administration is usually asked by most of the patients in clinical practice. And I think we should be very confident in defining that. The metformin should be preferably given before meal, because before meal, the absorption is better. And secondly, the effect in GLP-1 is more precise. However, those who do not tolerate, you can give with meal SGLT2, preferably in the morning, to avoid the nocturnal diuresis. Sulfonylurea 30 minutes prior to meal. That was the data from HEAP in patients with hypoglycemia. The DPP4 30 minutes prior to meal. Acarbo just before the major meal. Glitazones anytime, because they do have a more effect on the PPG before meals. Regular insulin 30 minutes prior to meal. Short-acting analogs 5 minutes only when the new glycemia is achieved. Otherwise, their lag time is also around 25 to 30 minutes. The long-acting analogs should be given at a fixed time. When to add insulin, I think in emergency admissions, no issues. When the fasting is more than 250, random is more than 300, hemoglobin A1C is more than 10, start insulin. Failure to achieve target hemoglobin A1C with optimal degree of 3, because by adding more OADs, now you see many prescriptions with 5 OADs. By adding more OADs, you have a more harm and you are not able to achieve the targets, mainly because the beta cell functions have declined too much. That's why you are not able to achieve the hemoglobin A1C targets despite adding 4 or 5 drugs. So the ideal is metformin, sulfonylurea or DPP4, SGLT2 or PI. If you have 3 drugs have been used in that way, then best is to add insulin. In a patient with gestational diabetes, yes, they preferably use only insulin and metformin, and a long-acting analogs versus premix insulin. So what should be the insulin after failure with OHE? I think now the debate is going on because the glargine versus the combination. So I think the glargine is possibly better because you target better fasting, and titration or self monitoring is better, and self-titration is also easier when you start with analogs versus premix insulin. Then what are the parameters which you should monitor? These are the parameters which we do in clinical practice like this, and ideally it should happen. So fasting in PPG for intensive control, at least 4 to 7.25, conventional control, and initially it will be weekly, but later on you can make it fortnightly. Hemoglobin A1C once in 3 months. Lipids once a year if the target is not achieved, then 3 months. Micronuria once a year. Fundus and foot examination once a year. A word about lipids and diabetes. We always used to have a debate initially that all patients with diabetes should be on statin. And now the criteria has been changed from an absolute value to reduction, 30 to 50% reduction on baseline, because 1/3 of the patients with coronary events, they do have an LDL below 100. So now the focus is on 30 to 50% reduction, age more than 40 to 75, because below 40, we don't have a robust data, and after 75, the life expectancy is reduced. So high intensity statin in those established CABD, while a moderate intensity statin in without ASCVD. And moderate intensity means 10 milligram of Rujua or 20 milligram of Atorva. Those between age 20 to 39, if they are the risk factors, statin can be considered. Ezetimibe or PCSK9, if there is a diabetes with ASCVD with LDL more than 70, should be added. Preferably, the statin should be given at bedtime because HMG coenzyme reductase activity is maximum at midnight. Triglycerides still remain a enigma, but if you are already ASCVD, risk factors have been taken care, LDL has also been taken care, and the TG is high, I think should be taken care as well. A word about hypertension, because one of the major killer to the diabetes complications is hypertension. So target is usually not defined. If there is a diabetic kidney disease, 130/80 and 140/90 for those who are not having a DKD. So this is the summary of the antihypertensives. So control of BP in type 2 diabetes will always require a polytherapy. It's one of the state of resistant hypertension. Hypertensive microanemic should be on ACE and ARBs. Normotensive microanemics, ACE and ARBs. Hypertensive microanemics, ACE, ARBs and SGLT2. Macroproteinurics, ACE, ARBs and SGLT2. Start with 2 drugs if initial BP is 160/100. With BP's uncontrolled use, intermediate active CCBs, hydrochlorothiazide, alpha blockers. It is associated CAD beta blockers. To summarize, the management of diabetes is a state of art in medicine. It has to be individualized. Diagnosis should be very confidently acknowledged. The clinical examination should be perfect. The choice of therapy is tailor-made because you have so many plethora of medications, so you have to use the drug very cautiously. And associated comorbidity should be effectively treated. Thank you. Thank you for your patience. Any questions or comments? I will be happy.
Thank you very much, Professor Pansali, for providing a crisp overview of such a vast subject. I know there could be so many different areas to pick on to ask, but maybe because of time constraints, we shall skip that. And we shall go on to the last case presentation.
So for case presentation number 6, I invite Dr.
But very sincere thanks to Professor Bansali once again for being with us on both the days. Thank you very much, sir.
Thank you, sir. Thank you, sir. Thank you for your very insightful presentation. We invite Dr. Neeti Agarwal, postdoctoral trainee at Medical College, Kolkata, for case number 6 presentation. And as examiners, we have with us Professor Thomas V. Paul and Professor Sanjay Bhadada. Both of them, of course, need no introduction. And as the case discussion progresses, you'll realize that both of them are not only national but global leaders in the realm of endocrinology, with which this case will delve into. So over to Dr. Neeti Agarwal to take us through the discussion and over the examiners.
Neeti, we are unable to see the presentation yet.
there. It's visible now. It's visible. You can enlarge. You can go to the presentation.
Okay. Good afternoon, respected teachers and colleagues. I'm presenting a case of a 57-year-old non-diabetic female patient who presented to us in November 2021 with complaints of generalized body ache since 4 months and dyspnea on exertion since 4 months. Patient was a known case of hypertension since 4 years, and she was currently on cilnidipine and telmisartan. Also, there was history of subclinical hypothyroidism since 10 years, patient being euthyroid with levothyroxine 50 microgram supplementation. Patient attained menopause at the age of 51 years. Examination revealed controlled blood pressure with antihypertensive medication. Patient was obese. Thyroid gland was palpable, not enlarged. Also, there were no nodule palpable. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema of feet, and systemic examination was unremarkable. Prior presentation to us in 2021, patient sought medical attention in 2016 somewhere else for her complaints of generalized body ache and numbness of extremities. At that time, routine investigations were done and those revealed hypercalcemia. These all are the...
Yeah, so the thing is, yeah. So, Dr. Niti, Dr. Sanjay is starting the questions, we will have some interruption here. We'll ask you some questions, and there are participants like Dr. Kaushal, Vanushree, all of them can answer. Dr. Sanjay, you are asking some question, please.
Yeah, Dr. Niti, can you tell me what are the common cause by your history so far?
Yes, sir.
By your history so far, what do you think? What can be the diagnosis? Because in clinical medicine, we believe on the history. So how seriously the history is taken, that is actually very, very important. By your this history, what do you think? What is the possible differential diagnosis 1, 2, 3, 4, 5?
So actually, my history was somewhat in form of a non-specific complaints like generalized body ache and dyspnea on exertion. So regarding other systemic involvement or if there is any involvement of
have you went into detail of the body aches? Means what do you understand by body ache? What is the localization?
This was the muscular pain. Sort of pain involving the generalized muscle pain was there.
How will you assess the muscle pain? How will you confirm clinically that this is the muscle pain, this is not the bone pain, this is not the superficial pain? How will you confirm it?
Sir, there was, we can assess for proximal myopathy or proximal myopathy or if there is
there is a difference in the pain and myopathy now.
Yes, sir.
Causes can be a myopathy with muscle pain, myopathy alone, muscle pain alone.
Yes, sir. Both are, yes.
Was it a bony pain or muscle pain or together? It was only a muscle pain.
Yes, sir. More a sort of muscular pain.
Because the complaint you're saying is sometimes patients will be so non-specific.
Yes, sir.
You have to get more out of it because each endocrine system, diseases can be specifically for certain diagnosis based on your history. Okay. Any other history you got it? Any other history? Okay. We'll come little forward, and you also told something like, she was earlier at another center diagnosed to have hypercalcemia, correct, no?
Yes, sir.
Okay, and also she has got a 2 comorbid illness. One is a hypertension. Number 2, she has got some hypothyroidism, probably primary hypothyroidism. Now, based on this, what history you want to add? We can ask Dr. Kaushal. Dr. Kaushal?
Yes, sir.
Based on this, what other history she has given one hypercalcemia is there, PTH and she has a hypertension, number 2, number 3 is hypothyroidism. So what else you want to know? History, just rattle it because we are running short of time.
Sir, sir, any history of proximal weakness?
Okay, then you go by system.
Okay, sir. Any history from CNS? Any history of mood changes or any like history of psychotic mons, or in the GI system, any history of the abdominal pain or past history of peptic ulcer disease or gallstone? For the general urinary history of polyuria or past history of renal stones.
Okay.
Then
what else?
Any history of fracture?
Fracture, yes, good. Yes.
Or
what
severe
else?
back pain.
Yeah. So they indicate indirectly. Okay. Dr. Sanjay, want to ask?
Yeah, no, it's okay. Yeah.
So what else? Pertaining to hypertension, you want to ask anything? Because we are a physician first. Like, you see the one more complaint, patient was having breathlessness on exertion. Am I right, Dr. Niti?
Yes, sir.
So
Yes, sir.
what do you want to know? Any other history? Dr. Vanishri?
Sir, I would like to ask history for cardiovascular disease. I would like to ask history for angina, any history suggestive of cardiac failure like pedal edema and orthopnea, other LV dysfunction features, since she already has dyspneic features.
Okay. Anything else?
Other complications of hypertension, sir, like renal complications, ocular complications.
Okay. So, based on this, you showed some investigations, Dr. Niti, in the previous slide.
Sir.
Right,
Yes,
no?
sir. Yes.
Can you please go back to that slide, if possible?
Yes, sir. This one.
No. The examination you showed something. Anything examination? Okay. What else you want to know? In this examination, is it complete based on so far? You got the past history, and now you go back. What else you will look for?
Okay. Sir, if there is any history of vertebral fractures or
No. On examination.
Sir, any spinal deformities or if there is loss of height and
what else? In the neck, what else you look for? No nodule palpable. What exactly you mean by no nodule palpable?
Sir, actually that a parathyroid lesion may be palpable. However, in case of parathyroid adenoma, it is not commonly palpated. It is more if the size is more enlarged. It is a case of parathyroid carcinoma. So, parathyroid lesion in that cases may be palpable. Or,
Dr. Sanjay?
There can be thyroid nodule.
Dr. Sanjay?
So there is, do you feel that parathyroid edema is not commonly palpable in Indian setting?
So pardon?
In patients of primary hyperparathyroidism,
Yes,
due to parathyroid adenoma,
yes, sir.
generally what percentage of patients are having palpable parathyroid gland?
Sir, in adenoma, no, sir. In adenoma, it is not encountered.
Okay, so
But there
my message to all participants is please read Indian literature, don't only read the Western literature. Okay? Almost all disease we have a different kind of presentation, different kind of analysis and all these things. So if you go any article which is published, good clinical article published by Indian scientists, you will know what percentage of patients having palpable parathyroid gland in parathyroid adenoma, not only in the parathyroid carcinoma. Okay. Anybody from the house want to answer this group? That what percentage of patients of primary hyperparathyroidism having palpable parathyroid gland?
Dr. Sandeep, you want to answer that question? Dr. Sandeep Mittal? You're there? Okay. Doctor,
I'm not sure, sir.
Not sure. Dr. Avasti?
So, we can tell them it is around 20 to 25% actually.
Okay.
Varying from 15 to 25%, parathyroid glands are palpable in parathyroid adenoma. Can you tell Dr. Niti what is the normal weight of the parathyroid gland?
Sir, normal weight.
Okay,
sir,
what is
I'm not sure. 1 to 2 gram. Yeah, I'm not sure, sir.
1 to 2 grams?
I'm not sure, sir. Sir, it should be less than that.
Anybody
Yes, sir.
from the
Yes,
group?
sir.
Anybody from the group?
60 milligram? 25 mg?
Okay, good. So 25 to 40 milligram is the normal weight. So that's why it is normally not palpable, and even normally it is not localized on the scan also. Okay, we'll talk on later about that. Okay, and okay, anything in this history you want to ask? Negative history, since you have a clue that patient had hypercalcemia from previous physician that informed that the patient had hypercalcemia. Any more history you want to ask as a negative history, and that is very, very important.
Sir, any history, since patient is a hypertensive, so any history of thiazide use?
Very good, extremely good. So thiazide use is fine. Anything else?
And sir, also, if patient is on any antipsychotic medications like lithium.
Okay. So you should take history lithium. That's correct. So drug history is important. Anything else? What are the common symptoms in patients of hypertension?
Sir, history of renal stones. History of renal stones, history of any fractures, or history of mood disturbances, generalized bone pains, or history of acute pancreatitis episodes in past.
Okay, good. So you have to take the history of abdominal pain in detail. Okay.
Yes, sir. There was no history suggested.
There is no such history. Okay. There is
Yes,
no
sir.
history of recurrent abdominal pain.
No, sir. No, sir.
Dr. Thomas.
Yeah. So in this, Nidhi, because of hypertension is also there, on examination, you have to do little bit of fundus examination. You have to mention whether there was a hypertensive, because you would have listened to Professor Bansali's talk previously of the examination.
Yes.
That will be better. Number two, hypertension, we cannot ignore it because the breathlessness,
Yes,
she just know.
Yes, sir.
So we have to
Yes,
see whether any
Yes.
renal artery bruit on the examination. Okay. So
Yes,
that
sir.
also.
Yes.
Okay. Go back to the next slide, please. Next slide. Next slide. Just because of the time. Right. So can I request Dr. Vadishri to comment on this investigation?
Yes, sir. Sir, the patient has frankly elevated calcium levels along with phosphorus on the lower end of the normal with an inappropriately raised PTH levels, suggestive of PTH-dependent hypercalcemia. Meanwhile, the renal function tests are normal. There is no renal dysfunction as of yet. And there is hypercalciuria as well with urinary calcium in excess of 4 mg per kg per day. So the calcium creatinine ratio is, however, borderline. It's 0.02.
Okay. So how do you make sure patient? How do you know patient has got a phosphaturia in this setting? If at all, in a hyperparathyroidism, you may get a low phosphate. We don't know whether it is a fasting sample. There is no mention because we always look for a fasting serum phosphate. Anybody else?
So we can do a TMP-GFR in
Yeah. Okay. For that, you need little more on the urine parameters, correct?
We need a urine phosphorus and we have a urinary creatinine as well. So with these 4 parameters, we can then calculate the TMP-GFRs.
Okay. Dr. Sanjay?
Yeah. So by looking at these parameters, we are going straight forward with the TMP-GFR, or you want to do something before going for the TMP-GFR estimation? By looking at this slide of investigations. Yes. What is vitamin D?
Vitamin D is low, sir.
So you will go directly, or you will correct first vitamin D and then you plan the TMP-GFR?
Yes, sir. It can mask phosphaturia. So first we will have to replenish the vitamin D, and then
first make vitamin D sufficiency, then you should go for that. Otherwise, it may be that might be patients having the component of both primary as well as the secondary hyperpara, and that may be a cause for the phosphaturia inhibition.
Right.
Okay. Okay. Any investigation you want further in this? You have more investigation. This is investigations are over here.
Dr. Niti, further investigations? Any
Yes,
further
sir.
investigations?
Yes, sir. Yes. Sir. So in 2016, patient 2016 imaging.
No.
We are just talking about the biochemistry, not going for the localization.
So, sir, biochemistry only these were available of 2000.
No. I've now given you the opportunity.
Okay.
That whatever you name it in, you have it biochemistry investigation. So anything you want further?
No, sir.
Okay, sure. Okay.
Yes, sir.
Okay, so I think Dr. Avasthi, what is your opinion?
Based on the above, it looks like it is a PTH dependent hypercalcemia, sir. So supportive investigations other than this, we might ask for a FGF23, but that won't add much to the.
No, I am not asked. I am sure we don't need the FGF23 at this stage, definitely. Anything more than FGF23? Okay. Kaushik?
Magnesium, sir.
Magnesium, sir. Magnesium.
Pardon?
Magnesium.
Magnesium. Very good. Good. Next. Mr. Dr. Vanishri, you want to add something more in this list of investigations?
Sir, I would like to work up for the complications of the condition as well. Like I'll do an ECG and.
No, I am just asking about the biochemistry. We'll talk about these. Mr. Mittal, Dr. Mittal.
Sir, to rule out any syndromic association, we can ask for prolactin to rule out MEN1, and patient is hypertensive also. So for MEN2A, we can ask for normetanephrine.
I think other important thing is this patient is in body aches now here, and we know as one of the common complication or common association of primary hyperpara is with what another association of metabolic bone disease. Anybody can tell?
Sir, hypokalemia, distal RTA, we should rule out.
Yeah, so you should look at that point of view also, because patients having body aches for a longer period of time. So you can have other investigations, including what type of RTA they do have hyperpara.
Distal RTA, sir.
Okay, just.
Yeah, so you need investigations for that also. That include your to calculate the anion gap. Okay.
Yes.
And that is required. And obviously, potassium, magnesium is the important components, definitely. Yeah. Dr. Thomas, please.
Yeah. No. Thing is, we can go to the next slide, please.
In 2016, patient underwent imaging studies for localization in form of a systemic scintigraphy, USG neck, and MRI neck, and all failed to localize the culprit parathyroid lesion. And patient was started on sinacalcid since 2016. However, when patient presented to us, she had discontinued that for last 6 months. Also, patient received single dose of IV zoledronate in 2016.
Okay. So you said imagings were done. What were the imaging? Ultrasound.
Sir, imaging, yes, USG neck was done, and system EP scintigraphy of neck was done, and also MRI neck.
Okay. So what are the sensitivity and specificity of these various imaging modalities for a single parathyroid adenoma?
Sir, for system EP scintigraphy, it is around, it has a sensitivity of around 70 to 80%.
How much?
For 70 to 80% for a single lesion, and USG has somewhat around 60-70% sensitivity. And as there is involvement of multiple glands, then for system EP scintigraphy, this sensitivity decreases around 30 to 50% only.
Okay, so you need any more imaging facility, because what do you think? What is the cause? It is not localized because of what?
Sir, this was the patient was not came to us in 2016. Patient came to us in 21.
Okay.
So yes, sir. Previous yes, sir. So so when patient visited to us, we repeated those imaging. This I will show in my subsequent slides.
Sure.
Okay, go ahead.
Okay.
So these were the trend of the biochemical investigation for the last 3 to 4 years. So during this time, patient was on sinacalcid, 30 mg twice a day. As we can see here, the serum calcium was in a normal range except for this time, present time, and serum phosphate was in a lower normal range or within normal range. There was persistent elevated PTH levels, and over these 3 to 4 years, there was a decline in the GFR was seen. Currently, patient had a serum creatinine of 2.17 and a eGFR of 24.8. Also, patient have.
No, okay. So what do you think? Like, so your obvious thing, what you're finding in this investigation, Dr. Sandeep, can you comment on this slide? Like, Dr. Nithya has put a serial investigations, and one obvious thing is PTH is slightly going up, and we don't know the same assay. We don't know, it's a different lab, but at the same time, creatinine we see it has gone up and eGFR is dropping. So can you please comment on that?
Yes. So in this case of PTH dependent hypercalcemia, the renal function has declined. That may be because of nephrolithiasis, or this can be an acute kidney injury because of the dehydration related to hypercalcemia.
See, any other comments, Dr. Kaushal? Dr. Avasthi?
Sir, the decline in renal function might also be associated due to hypertensive
excellent
kidney as well.
Yeah, that also has to be taken, because we are looking at the two different conditions. Correct, no? Dr. Sanjay?
Yeah. So absolutely correct, because hypertension is important one, but I want to say who said the dehydration. I just want to make him correct that dehydration cannot persist from 4, 12, 19 to 30, 11 to 11, 21. Okay. 2 years dehydration is less likely. Okay. So this dehydration cannot explain alone all these things. So of course the hypercalcemia can have dehydration. Another interesting thing, why the phosphate is low, 2.1, 2.5, in spite of the rising creatinine, patient on sinacalcid is very, very interesting, because sinacalcid is used for the treatment of hypophosphatemia. And you see that patient is on sinacalcid, and CKD is there. So what is explanation for this? How you explain this low phosphate? Yes, Niti, would you like to say something?
Sir, for last 6 months, patient was off Sinacalcet. However, in 2017 also, his phosphate is in the lower range. So, so because of disease per se, because of hyperparathyroidism causing phosphate wasting.
No, but if the CKD is
yes.
how can it can be parathyroid phosphate was resting?
Yes, sir. I think.
And now vitamin D is also normal. Even earlier the vitamin D deficiency was
yes,
there.
Sir. Yes, sir. Yes, sir.
So I think one thing is you need look carefully on this. Other thing is sometimes RTA can be one of the things. Why the phosphate is low? I don't have the potassium to comment on all these things here.
So, Dr. Niti, can you connect hypertension and hyperparathyroidism together? How do you connect, say, primary hyperparathyroidism with the hypertension?
Yes, sir. It can happen. Yes, sir.
It can be.
Yes, sir. It can be. It can be because of as a causal association also, or as a
yes, very good. So, what are the causes? Okay, sure, good. So, you tell me 1 or 2, 3 associations can be.
Sir, over a long run, primary hyperparathyroidism can predispose to formation of causing atherosclerosis and carotid plaque formation.
Sure. Okay. That is one. Number 2, in association with syndromes, you can get correct.
Yes,
no,
sir.
But not in
yes,
this case. We are suspecting.
Yes, sir. As a form, yes, sir. In syndromes like MEN2A, where there is associated few groups.
What else? Anybody else? What about renin and aldosterone? What happens?
Sir, then
any
we
association?
Elevated. Yes, sir, elevated aldosterone levels.
Okay, renin and aldosterone can be. These are some association. Okay, we'll go to the next slide, please.
We did a USG abdomen was done, and there was no evidence of chronic kidney disease. Also, there was no evidence of nephrolithiasis and nephrocalcinosis.
Do you agree?
Dr. Sanjay.
Do you agree with this ultrasound report?
Yes, sir. Yes, sir. It was done twice, and there was no evidence.
So if the creatinine is 2.17,
yes, sir. Yes, sir.
57, or even lesser than that, actually.
Yes, sir.
So how is it possible that ultrasound is absolutely normal? It's fine. Nephrolithiasis, nephrocalcinosis may or may not be there. That's fine. But the corticomedullary differentiation, all these things doesn't go hand in hand with the biochemistry. Either the biochemistry is having some problem, or this ultrasound is having some problem. Okay. Yeah. Dr. Thomas, please.
Yeah. What else you look for in ultrasound in a PHPT? What else in the ultrasound abdomen other than kidneys? What you mentioned already.
Pancreas.
And?
Pancreas to.
Correct. Calcification. Then what else? Which other organ? Which other organ? Gallbladder. Somebody told no already.
Yes, sir. Cholelithiasis. Yes, sir.
Okay. Just 1 minute, Dr. Soumik. How much more time we have? Can you tell us?
Sir, we have around 20 more minutes.
Okay, sure. Just 10, when it reaches 10 minutes, can you let us know, please? Thank you.
Definitely.
So, Doctor, okay. So you look for gallstones, you look for pancreas calcification.
Yes,
okay, correct. So this both kidneys, normal size, cortical echogenicity not raised, maintain corticomedullary differentiation. Okay. But for the creatinine, sure. Okay. Go to the next slide, please.
Also, bone mineral density.
No. You just talk I am going to ask Dr. Sanjay. Shall we ask one of the student? No. Next slide.
Yeah.
Yes, sir.
what is it correctly represented, Dr. Kaushal, this BMD values? Any error?
Sir, the unit is should be gram per centimeter square.
Yes. Why?
Sir, it is an aerial BMD value. It's not volumetric BMD.
Yes. Good. So what is the interpretation of is it like, if you look at this BMD, she has she's menopause for last maybe 6 to 7 years, and she has a primary hyperparathyroidism. So this BMD value is as per the expectation, or it is surprising? Dr. Avasthi?
Sir, this is slightly surprising, but however, in the context of primary hyperparathyroidism, it is fitting, as there is more of cortical bone density loss in the distal radii in both the upper limbs, sir.
Dr. Sanjay? Yes, sir. Okay. So, right. So, thing is, you see a T-score of minus 6.5. Dr. Sanjay, you want to comment?
I'm just curious why they've done the BMD on both radius. What is the purpose of this left side, right side? Generally, we don't do like that. So, what is the interpretation of this DEXA scan? Yeah, anybody? Dr. Seth?
Yes, sir. Sir, it is like clearly osteoporosis on the basis of the score at the radius.
Suppose this patient is not having the primary hyperparathyroidism, what you will do? Will you treat this patient or will you not treat this patient?
Sir, only on the basis of the radius score, there is no like in the guideline. Guideline only includes spinal bone density and femoral neck bone density till now.
Okay. So anything better modalities are available to study the bone health?
Yes, a trabecular bone score we can do.
Okay.
Because she is menopausal and primary hyperparathyroidism long time, still spinal score is minus 1.5.
Dr. Kaushal, no? Dr. Kaushal. See, basically, available, like, sometimes L1 to L4 lumbar spine score can be deceptive, because you may have to simple modalities even before TBS. You can do an X-ray lateral spine to see the other artifacts, because you may get a falsely low value. It's a total they are given. We don't know what happens to L1, L2, L3, L4 and all that. So that is one. You can see the extra, and also trabecular bone score. Dr. Sanjay, you want to add?
Yeah, I think I don't want to say more anything on this particular slide. Yeah.
Yeah. Next slide, please.
In order to localize the parathyroid lesion, we did a 99M technician system image scintigraphy.
So what is the principle on which the systematic scintigraphy works?
Pardon?
What is the principle of the systematic scintigraphy?
Sir, here the 99M technetium is the cation which emits the gamma rays, and this MIBI is the chelating agent, and a hyperfunctioning parathyroid gland, since they contain an abundant number of mitochondria. The oxyphil cells, they contain an abundant number of mitochondria. So the more the number of oxyphil cells, the more is the functional activity of this gland. So they more retains the system maybe. And thus they appear as they show a uptake on the scan.
Okay, fine. Yeah.
So in this scintigraphy, both early phase and delayed phase was taken, and as we can see here, uptake was seen in the early phase in the thyroid region. However, there was no uptake seen on the delayed phases. And also we included the mediastinal window so as not to miss any ectopic parathyroid lesion. This was then followed by a SPECT CT in order to have a three-dimensional view and a better resolution of the lesion. A SPECT CT showed a lesion over inferior aspect of the right lobe of thyroid gland. However, it didn't show any abnormal uptake compared to surroundings. So, on having a close view of the CT scan plates, we found a lesion over the right side, just inferior to the right lobe of thyroid, in both axial cuts and the coronal views. This one. So we did a USG neck so as to localize the parathyroid lesion, and also our plan was to if had any suspicious lesion being found on the USD, then we planned to do a fine needle aspirate from that suspicious lesion, so that from the washout of that fine needle aspirate, PTH measurements could be done. However, USG neck revealed multiple colloid field nodules in both lobes of thyroid, and also a poorly defined lesion was seen below the right lobe of thyroid. It was poorly delineated, and also it was close to major blood vessel. So fine needle aspiration could not be done.
Okay.
And
so
we were not, and also as patient had CKD stage 4, so 4D CT scan could not be done, and we were not having the facility of 18F choline PET scan. So we were not able to localize this parathyroid lesion.
Fine. Yeah. So if you are unable to localize, what is your plan now?
So, sir, as we were not able to localize the parathyroid lesion, so our plan was to do a surgery, a bilateral neck exploration with identification of the 4 parathyroid glands. But patient refused for surgery.
Mm-hmm.
So we offered the medical option to the patient, and we started her on Sinacalcet 30 mg twice a day. Also, the other issue was management of osteoporosis, as patient had a declining GFR, so bisphosphonate could not be given. So we gave patient denosumab 60 milligrams subcutaneously, and it was planned to be given 6 monthly.
So basically, you combine both the drugs, Sinacalcet and denosumab?
Yes, sir.
Okay. So what is the basic purpose of giving denosumab?
Sir, for
hypercalcemia or for the BMD?
No, sir. So for benefit over the bone mineral density. Not for hyper. Not for hypercalcemia.
Not for hypercalcemia. Okay. And Sinacalcet you give in what doses?
Sir?
Sinacalcet in what doses? 30 milligram.
Yes, 30 milligram twice a day.
So we have about 10 more minutes.
Okay, okay. So how will you monitor this after on the Sinacalcet therapy to patient? How will you monitor the patient on Sinacalcet therapy?
Sir, with Sinacalcet, sir, we expect a normalization of serum calcium levels, and also PTH level can decrease with Sinacalcet. However,
Sinacalcet reduces how much calcium and how much PTH?
Sir, how much calcium
Yeah,
reduction?
to what extent it can reduce the calcium
Sir,
level?
sir, it can normalize the serum in the normal range. It can normalize the serum calcium in
Suppose
the
a
normal
person
range.
is having calcium of 14, will it normalize to
Okay. No, sir. Around 1 to 2 mg per day.
Okay, we can check it. And how much PTH it reduces?
Sir, PTH is generally expected to be 30 to 50% reduction into the 30 to 50% reduction in the PTH levels.
So, and when do you stop the cinacalcet? At what level of PTH you have to stop the cinacalcet? Or you will continue?
Sir, we can continue that for around for 2 to 3 years, so it can be given.
No. This continue means that one thing is, so you will follow the patient now. So my
Yes, sir.
question
We'll
is,
follow. Yes, sir.
how
We'll follow
long,
the
how
patient.
long and what are the parameters you will follow? And what changes are there when you stop the cinacalcet, you increase the dose of cinacalcet?
Sir, we will follow the patient by monitoring serum calcium levels and then PTH levels. And generally, urine calcium levels are not affected much with cinacalcet use.
Okay. So that's why I'm telling you, I am asking the question, when will you increase the dose, or when will you decrease the dose, or when will you stop the cinacalcet?
So that I'm not sure of this.
Dr. Vanishri, you want to answer Dr. Bareda's question? Sir's question. How do you monitor somebody on cinacalcet? She said she has started this patient on almost 60 milligram per day of cinacalcet. When do you call the patient for follow-up, and what are the monitoring parameters?
Sir, we can call the patient after 4 weeks after starting, around 2 to 4 weeks after starting cinacalcet, and then 3 monthly we can follow up with the calcium levels, sir. And PTH maybe every 3 months.
So, Vanishri, here the patient you are giving cinacalcet, you are giving a patient denosumab.
Yes,
and
sir.
patient's creatinine is 2.17. What catastrophe can this patient have?
Hypercalcemia can happen, sir.
Hypercalcemia is there already. So what can happen?
What happens to bone?
The patient may develop hypocalcemia, sir.
Severe hypocalcemia.
Severe hypocalcemia.
Because denosumab in CKD is otherwise also one of the precautions. So that's why it is advised on day 7 of initiation of cinacalcet, you must look for the serum calcium levels. And the CKD is one of the risk factors, they can cause severe hypocalcemia. Okay, Dr. Thomas, please. Yeah.
So then what about, see, sir, adding to sir's question, what is a PTH? See, we have a little different scenario. In addition to PHPT, patient has got a CKD. And what's the PTH you want to keep?
Yeah, target PTH.
Sir, less than 200 or.
So your answer should be like, what is your normal range in your lab? What is the normal range? You tell me.
Sir,
What is what assay you're using?
Range,
No. You're asking plasma PTH or serum PTH? What you're doing there?
Plasma PTH.
Which is better?
Sir, plasma.
If you are given a choice, which plasma PTH is better or serum PTH is better? Then why?
So then serum. Then sir, serum.
Serum is better. Anyone else has a different opinion? Doctor? Only, see, you are 50% right, no? Like only 2 choices. Not like neat. 25% possibility. No? So,
and negative marking also there.
Okay. So what, there are concerns about, do you have, that PTH has a short half-life, like ACTH, and there are, enzymes which can degrade. So you, in a plasma PTH, because there is a preservative to keep it as plasma, the degradation is slower compared to serum. So they predict serum is more, plasma is better than serum. Of course, this is a theoretical description. Right. So what is your normal lab cutoff, Dr. Niti? In your lab, what is the
Sir, it is between 14 to 72 picogram per ml.
So what is the range you want to keep? Like in a CKD, what happens if you suppress the PTH too much?
So
Already you given denosumab also.
So there can be a dynamic bone disease if PTH is suppressed to a significant level.
Dr.
in
Sanjay?
CKD patient.
Yeah. So, Niti, how do you know that patient is having the dynamic bone disease? What are the parameters you look in this patient?
Sir, alkaline phosphatase, marker of bone turnovers. If the alkaline phosphatase is in the lower range, or if it is low.
Anything better?
And very low serum phosphate level also.
Very low serum phosphate. Why not bone specific alkaline phosphatase?
Yes, sir. Bone specific alkaline phosphatase.
Yeah. So I think we have just few minutes only. So
Sanjay, you want to, Doctor, you wanted to tell your teams, the choline PET, they may be interested.
Yeah. So choline PET can be done, I think, in this patient. If the facility is available nearby, they can get it choline PET CT. But otherwise, by that time, maybe foreground hyperplasia might be there because patient is having now CKD and EGFR is very less. 57, I believe last one is there. And otherwise, his medical treatment is okay, but I am worrying if Dr. Thomas was telling also that patient might be having additional cause for deterioration in this kidney function rather than just having the PTH. Because over the period of 8 to 10 years, generally, mild to moderate hypercalcemia does not cause severe kidney disease, and especially when patient does not have nephrolithiasis, nephrocalcinosis, anything is not there. So I think we have to look for some other cause, and that maybe hypertension is one of the important one. So look for the detailed workup for hypertension and look for the control of blood pressure also.
And also urine protein, urine sediments, all this, as a physician, like, because patient has come with some, breathlessness, that all have to be addressed. Of course, this is one aspect as an endocrine, but as a physician, we may have to look at, as Dr. Badera said, like, the hypertension, whether it is contributing to a decline, because this much of thing, we don't think it's a PHPT has contributed to this kind of decline in the EGFR.
Yeah. So, and other thing is, I may not be very much in favor of treating this patient with the denosumab because BMD low at the radius does not really require any idea to increase the BMD at that site because we are not bothered about the radius BMD. So, few quick rounds. This parathyroid gland was first identified in where? To Avasthi.
Yes, sir. What is the question, sir?
Parathyroid gland was first described where? First description of parathyroid gland.
I don't know, sir.
Okay. Agarwal, Niti Agarwal, what is the connection between India and parathyroid gland?
It's a further clue.
Doctor said, what is the relation between Commonwealth countries and parathyroid gland?
I don't know, sir.
Okay. So this parathyroid gland is first identified in the Indian rhinoceros in the British Museum. Okay. So that is some relationship with this primary parathyroid gland and the India. So that's all. Over to Dr. Thomas.
Yeah. We'll just file words. Okay. So the bottom line here is when we have a patient like this in our clinical setting, in addition to look into endocrine aspect, we have to also, as a physician, to look at the additional clues and additional causes. So that may be first sometime. And also the overall comprehensive history and comprehensive evaluation. That's it. And otherwise it's so good. And I like to thank Professor Subhankar and team, Doctor, for this opportunity, and thank you very much.
So I also echo with Dr. Thomas, Dr. Soumik, sir, and the whole team for this.
Dr. Soumik, thank you very much.
Thank you. It's a really interesting case to discuss, and I hope it was useful discussion. And thank you very much for this opportunity. Thank you.
Thank you very much, Sanjay and Thomas.
So with that, we come to the end of case discussion 6. And once again, we would like to extend our heartfelt thanks to both our examiners, Professor Sanjay Bhadada and Professor Thomas Paul, who made that very difficult bone case look relatively easy. With that, we have come to the final session of this year's Endocrine Enrichment Program, EEP 2022, and we have been waiting for the results of both the Endocrine Hawk Eye and the Endocrine Wise Owl. We are very happy and privileged to announce that 2 very senior examiners and faculty members, Professor Anil Bhansali and Professor S.K. Singh, have graciously accepted our invitation to announce the results of this year's Endocrine Hawkeye and Endocrine Wise Owl. So for the Hawkeye, any one of you could be a potential winner, any one of the 70 entries which we have received yesterday. And I invite Professor Anil Bhansali to first announce the results of the Endocrine Hawkeye. The winner gets the coveted title of Endocrine Hawkeye besides 25,000 rupees. The first runner-up gets 15,000 rupees and the second runner-up gets 10,000 rupees. And I think we have an interesting result to be declared soon.
Yeah. So thank you Soumik, and thank you Shubhankar for giving me this opportunity. I feel privileged. And so the results of the Endocrine Hawkeye, they are very interesting. Like the cases were also very interesting. So this is also interesting. So the second runner-up it is a joint. There are 2 winners in fact. One is Dr. Kaushal V. Sheth from Yashoda Hospital, Sikandrabad. And the second is Devaditya Das from IPGMER, Kolkata. So the 2 second runner-up, they are a joint winner, and congratulations to both of them. The second, Devaditya Das. Soumik?
Yes. So
yeah, I'm not seeing. Yes. Okay.
A big round of virtual applause for both of them. We now move over to the first runner-up.
Okay. Now we go to the first runner-up. Is Ahmad Alam from BHU Varanasi. Congratulations, Ahmad. And now the most awaited is the winner of this Endocrine Hawkeye is from our institute, Anirudh Shetty from PGI Chandigarh.
So big round of applause, virtual applause for Dr.
Congratulations, Anirudh. Yes.
Congratulations.
Congratulations to all of you. And thank you to Shubhankar and Soumik for giving me this opportunity. Thank you.
Thank you, Professor Bhansali, for helping us declare the results. And I can say that it was a very closely fought contest. Everyone fought tooth and nail, and we had to keep ourselves awake till midnight yesterday to find out the winners. The number of negatives, the number of positives, everything had to be taken into account. I now request Professor S.K. Singh to declare the results of the contest that we had a short while ago, the Endocrine Wise Owl, where you had to critically analyze the article. We had 5 finalists from 29 entries which we had received earlier, and we will have 3 winners. The winner, of course, gets the title of Endocrine Wise Owl for 2020, as well as an award of 25,000 rupees. The first runner-up gets 15,000 rupees, and the second runner-up gets 10,000 rupees. Over to Dr. S.K. Singh to declare the results officially for this year's contest.
Thank you, Soumik. First of all, I congratulate Dr. Subhan. Had been for a long time. I've seen this. So really like cow enjoys milking.
There is some
So the students.
Yeah, now it's better. Yeah, thank you.
Okay. Young game of Soumik and team. The second runner-up is Dr. Arjit Singha from IPGMR, Calcutta. Dr. Arjit Singha. Congratulations to Dr. Arjit. The first runner is Dr. Krishna Prabha. Dr. Krishna Prabha. And the winner of Endocrine Wise Owl, Dr. Johan Varghese, Andhra Medical College. Dr. Johan Varghese. Congratulations. Congratulations to all the winners. Be it second runner, first runner, or the winner is all same. It's wonderful.
Thank you. Thank you, Professor Singh.
Thank you.
Thank you. So a big round of virtual applause and congratulations to all the winners. In fact, congratulations to all the participants because your active participation actually made this event possible, made Endocrine Enrichment Program 2022 possible. With that, I ask our course director, Professor Shubhankar Choudhury, to give us his concluding remarks about this year's program and deliver the customary vote of thanks. Over to Professor Choudhury.
Thank you very much. First of all, my sincere thanks to all the participants for being actively involved over this couple of days. We, of course, had the benefit of the best of senior people to be there as guides, examiners, and also to a lecture. And we had two excellent quiz masters yesterday. I'm sure everyone would agree. And we of course, sorry, I'm missing out on the judges who spent a lot of time actually initially going through the papers and then evaluating the presentations. We have two excellent quiz masters in Dr. Soumik Goswami himself and Dr. who made things very interesting and I hope also was educative to several of the participants. This program, of course, would not have been possible without the very active help and enthusiasm of INTA's team. This is led by Mr. Bharat. So, my sincere thanks to all of them. And we have a few learning points maybe on our side as well. I found that each one of those presenters at the Endocrine Wise Owl crossed the time limit. Maybe we were a little bit strict about keeping only 4 minutes. Maybe next time we will keep it at 5 minutes. But we would once again request you all to send in your feedback so that hopefully we do it better next time. Even this time we could not have a physical program. Hopefully we'll have a better physically attended program next year. So till then, all of us, let us keep safe, healthy, happy, have a great new year ahead. And thanks once again to all of you.
Thank you.
And with that, we come to this edition of the Enrichment program. And I hope we meet again soon. Thank you.
Thank you and bye-bye.
Thank you, sir. Thank you. Bye-bye.